Now we are live now.
Okay. Very good evening to one and all of you for our ARC webinar on the update series in tips and thoughts for a universal safe surgical system in glaucoma. I truly believe that this is going to be an amazing 2.5 hours because we have the most awesome set of expert panel and a great set of speakers and wonderful talks. And I'm sure all of us are going to be glued to the webinar in the next couple of hours or more. We are truly lucky to have with us on the expert panel, Dr. Harsh Kumar, who's the Director of Glaucoma Services of Center for Sight Group of Hospitals based at New Delhi, a very eminent glaucomatologist of our country who just needs no introduction. Joining us shortly is going to be Dr. Satyan Parthasarathy, who's the Director of the Satyan Eye Hospital and Coimbatore Glaucoma Foundation. Dr. Satyan is again another very versatile surgeon, very experienced and reputed ophthalmologist from Coimbatore. Dr. Chandrima would be unable to join us, and she is the Director of and Consultant Glaucoma Services from BBI Foundation, Kolkata, and also the Honorary General Secretary of Glaucoma Society of India. It's our ill luck that she's not able to be with us today. Joining us soon would be Dr. Ramanji Sihota, who's again a Senior Consultant Glaucoma Services from Shroff Eye Center, New Delhi. And she's also the very popular ex-professor and head of glaucoma services of RP Center, who has yeoman contributions in the field of Indian ophthalmology. We are very lucky to have with us Dr. Craig Chaya, who's an internationally renowned glaucomatologist from the University of Utah. His essential focus is on medical and surgical management of routine and complex cataracts and glaucoma at the John Moran Eye Center, Salt Lake City. He's the assistant clinical professor in that university, and his research interests are also very interesting, which involves novel glaucoma surgical devices and international blindness prevention. Joining us soon is again Dr. Krishna Das, and I'm truly indebted to have him in this webinar. He's the director of the HR department of Arvind Eye Care Systems and is a senior consultant glaucoma services from the Arvind Eye Care Systems based in Madurai, and is a truly prolific glaucomatologist of our country. I'm lucky to have moderating with me Dr. Muralidhar, who's a senior consultant in glaucoma, pediatric ophthalmology, strabismus, and neuro-ophthalmology. Name it, he is all of it at the Eye Foundation group of hospitals. Again, a very astute and proficient surgeon in our Eye Foundation group of doctors, and he is going to be there all through guiding the course of this webinar. So without ado, we shall go on to our first speaker, Dr. Satyan Nagamallai, who is the president of IMA Society, IMA of Coimbatore, and also is a medical director of the Eye Trust Hospital and Kobe Glaucoma Center, a very versatile, young, dynamic surgeon. And he is going to tell us something very relevant. How do you identify the patients at a high risk of complications from glaucoma surgery? That's a challenging topic. Let's hear you make it as interesting as possible. On to you, Dr. Satya.
Thank you. Thank you very much, madam. I think my screen is visible.
Yes, yes, yes.
So, good evening, everybody. I'm Dr. Satyan Nagamallai from Coimbatore. I thank AIOS ARC and Dr. Chitra Ramurthy madam for giving me this opportunity. I'm here to talk about identifying patients at high risk of complications from glaucoma surgery preoperatively. So glaucoma surgery is an option in case of resident cases where IOP could not be controlled with maximum medical therapy. This surgery disrupts the globe integrity, leading to complications. To reduce these complications, surgeons should know how to recognize and anticipate preoperatively, to take preventable surgery steps intraoperatively and manage them accordingly. So Cranes described Travicolotomy in 1968, and still it remains a global standard. And the pre-existing risk factors and success augmenting mood modulating agents led to various complications. And timely detection pre-operatively and intraoperatively and managing it is vital for good surgical outcome. So I'm here to talk about 10 pre-existing factors which might influence the outcome of glaucoma surgery pre-operatively, and it helps in preventing glaucoma surgery, glaucoma surgery related complications. So patient, number one factor is the patient age. Younger the patient, you have to think about whether you have decide whether you have to going to do the surgery under local anesthesia or general anesthesia. If it is general anesthesia, there are IOP modulating general anesthetic drugs which has to be taken into consideration. And younger patients are known to have thick tenons, and excising it or managing it accordingly will help in preventing fibrosis, where younger patients have higher risk of fibrosis. When you think about operating older patients, fragile thin conjunctiva, which is opposite to younger patients, and careful handling of conjunctiva during the surgery to prevent conjunctival tear or buttonholing, which is one of the commonest complications encountered by the surgeons. And risk of systemic factors like diabetes or hypertension. Diabetes in case uncontrolled can produce a risk of infection, and hypertension can induce bleed. And older patients with advanced glaucoma have much higher chance of wipeout compared to younger one. So second factor is patients on anticoagulants need to stop prior to surgery at least 3 to 5 days according to the based on the advice from the physician. And when patient on anticoagulants with retrobulbar block can lead to acute retrobulbar hemorrhage, proptosis, SCH, and retrobulbar associated bleeding as risk factors. And it can also compromise optic nerve blood supply, and can also lead in difficulty maintaining hemostasis during surgery, which is very detrimental for deciding the outcome of glaucoma surgery. And excessive intraoperative bleed can predispose to blood failure and difficulty in suture lysis even after 2 weeks. And these patients can have an additional risk factor with the risk of suprachoroidal hemorrhage. Other risk factors of increased intraoperative bleed, as I said earlier, is uncontrolled hypertension. Never touch a patient. Measure the blood pressure prior to surgery, and look for these patients whether they have taken those medications on the day of surgery. And patients with increased capillary fragility has to be considered for risk of bleeding, and hemostasis has to be achieved based on that. Coming to the third risk factor is the refractive error. When you do a refraction in these glaucoma patients, look for high myopia and hypermetropia. And when you think of high myopia, then these patients will have the tendency to have thin sclera, and these have higher risk of suprachoroidal hemorrhage. And hypermetropia, these patients have shallow chambers and additional risk of malignant glaucoma. Then, so doing a refraction and knowing the refractive status prior to glaucoma surgery is very, very important. Coming to the fourth risk factor, very high pre-op intraocular pressure can lead to thin scleral flap when you are raising it, because when the globe pressure is higher, then the tendency for us to create a thin flap is much, much higher. So we have to be very careful about it. Then premature antechamber entry, choroidal detachment, and sudden decompression. So I gently use a side port, keep the side port in the side port until required decompression has happened very slowly. So you should not remove the side port suddenly. It can lead to sudden decompression and choroidal detachment. And these patients with advanced cupping can have a risk of wipeout phenomena. So adequate reduction is mandatory for reducing the risk of complications pre-operatively. Reduce the intraocular pressure to an optimum level to prevent these complications. Coming to the fifth factor, the conjunctival factor. Conjunctiva plays, as I said earlier, older patients will have thin and fragile conjunctiva. Likewise, patients, when you are planning for a repeat RAP in a previously operated eye with scarring, then these patients should be carefully examined in the OPD. Look for a viable conjunctival area, mark or draw it in the case sheet prior to taking up these patients for surgery, and these areas should be marked in the OPD prior to the surgery. Very, very important. And inadequate space for repeat filtering surgery, in my experience, have problems with suturing and early bleb leaks, So you have to be very careful about not involving the adjacent bleb or the conjunctiva which was influenced with mitomycin have a tendency to leak more when compared to a primary trap, so conjunctiva. So two nasal or two temporal areas, technically difficult and challenging, and risk of infection and injury is very common when these blebs are exposed outside the lid coverage. Patients on long-term glaucoma medication can lead to meibomian gland dysfunction and excessive fibroblast migrations. I generally stop drugs like prostaglandin, pilocarpine, bromelain 3 or 5 days prior to surgery and put them on topical steroids, and can control intraocular pressure with oral medications. Look for Sturge-Weber syndrome and plan the surgery in Sturge-Weber syndrome based on the area without dilated episcleral veins, and we should be careful about positive pressure and bleeding. Coming to the sixth risk factor, sclera. Look for thin sclera in case of congenital disease like osteogenesis imperfecta and acquired like iron deficiency anemia. Nothing wrong in doing a hemoglobin, especially for a woman who is planning to undergo a glaucoma surgery to rule out iron deficiency anemia. Then people with high myopia, as I said earlier, has thin sclera. Chronic inflammatory disease like rheumatoid arthritis and scleromalacia preference has the tendency to have thin sclera. You have to be very careful about, and previous scleral injury has to be looked for. So careful about retrobulbar block in case of thin sclera, and also very careful about raising flap, and a wise decision about using antifibrolytic agents is very, very important. If you feel apprehensive, then probably you can use a spacer or tissues like collagen tissues like collagen to prevent any scleral related complications. Coming to the shallow entry chamber, these patients are of axial hyperomic chronic angle closure with PAS. There is an increased risk of aqueous misdirection, post-operative shallow chambers, and careful about lens touch when you are entering the antechamber. Positive pressure and iris incarceration into the ostium are all factors which you have to keep in mind when you see a patients with shallow chambers. And these complications or risks are higher regardless of having patent iridectomy or iridectomy. Coming to iris, eighth risk factor, peripheral anticyanic can lead to iris damage during surgery, iris incarceration into ostium, and risk of malignant glaucoma. And neovascularization of iris can lead to intraoperative bleed and progression of fibrovascular membrane in the angle. So it can be usually combined with anti-VEGF factors, while or at least 3 to 4 weeks prior to a TRAB, you can have an anti-VEGF factor injected, and then you can plan for a TRAB. It works very well. Coming to lens, look for aphakia.
You have 1 minute remaining, sir.
Yes, sir. It's about to finish. Aphakia, look for aphakia and vitrectomized eyes, and these patients have higher risk of suprachoroidal hemorrhage. Spirophakia, we have to take a decision of doing a trabeculectomy with or without lensectomy, which carries variable success rate. It's surgeon's purview, and you have to decide whether you are going to do a TRAB with or without lensectomy. Coming to the 10th and last risk factor, advanced glaucoma, advanced cupping with tubal fields. Look for macular split and 10-2. It's a medical legal requirement. So need to explain the risk of wipeout phenomena prior to surgery, and document that you have noted a macular split and you have explained about my wipeout phenomena to the patient and the attenders, and get a proper written consent. So conclusion, careful pre-op evaluation will help in better planning, modifying surgical technique, and preventing post-op complications. Thank you. Thank you very much for the opportunity.
Thank you very much, Dr. Satyan. That was a wonderful talk, and I think you left nothing uncovered. So, but however, we would go on to discuss. Dr. Harsh, you are there with us. Dr. Harsh, are you there?
Yeah, okay.
I was just
so,
wondering,
Chitra,
I wanted to ask a question. Are there any category nowadays? Is there anything there when you would think of not using metabolites in a trabeculectomy surgery? When you would think about using it? Some of which, of course, Dr. Satyan alluded, but however.
Yeah, there are two important things. One is that we just are going to publish a paper about trab in pregnancy. So
Okay.
obviously, in those situations, you just cannot use. As a matter of fact, uh, there's no way you are going to use any chemical over there as and when you want. The second thing is that
What would be your explanation for that?
no, because especially in first and second trimester, you are really wary that there could be some kind of a problem with the organogenesis and things like that. So you definitely, at least in the first trimester, you will definitely not like to use any this thing fibrotic. The second thing is in high myopes, like I think he very rightly pointed out, and when sclera is thin, you would probably go for collagen. And I just wanted to fill in that in situations like this, sometimes we have already published a paper in 2008 where we used anti-VEGF. And I can promise you it works wonders. I know it is an expensive thing, but the point is when nothing else is there for you to cover up, the anti-VEGF actually serves the same purpose as the anti-fibrotic. It prevents fibroblast migration. It prevents the vascularity for 3 weeks, and that is what you want for the bleb to form. So I think one has to be.
And would you think a little differently in some of the systemic collagen disease? I mean, I myself would like to know collagen vascular disease. And would you at all think in an elderly patient with fragile conjunctiva, like I would use an antimetabolite there, but I want to be corrected if any of you would think of using a lower dosage in those cases? If the conjunctiva looks very thin?
Classically, if it's a thin conjunctiva, old patient, I don't think we really need it at all. The problem is that now in practice, I think we are also tensed up that the patient should not fail. Yeah. And I think we are a little overusing it. But yes, you are absolutely right that possibly if we are going to use it, we are going to use it for lesser concentration and lesser time. Yeah, yes. That's right. Absolutely.
Yeah. Dr. Krishna Das, are you there? He has not joined in yet. Okay. Anything else you would like to add, Dr. Harsh?
Yeah, one very important thing is that if the other eye has got problems, so you see many times that one eye has gone into malignant glaucoma post-surgery, then you have to be very, very careful because the other eye can also land up with those kind of situations. So that is one point that we have to be careful about.
And the other important thing, would any of us still consider stopping the topical steroid drops to avoid chances
Dr.
of...
Chitra?
Yes,
Dr.
yes.
Chitra? Yeah, I can be heard now. Yeah. I just wanted to add a couple of things to which you and Harsh had actually added value.
Yes.
One is in juvenile glaucomas. In most juvenile glaucomas, with especially onset lesser than 30, 35 years, the sclera tends to be a little fragile, tends to be a little inelastic and less resilient than in adults. So in these group, the hypotony maculopathy is much more common, especially when we overuse or use higher dose of mitomycin. So it is in this group I totally avoid. And next, in very high myopes, again for the same reason you mentioned in collagen vascular disease, when sclera tends to be thin. In most myopes, the sclera also is less resilient, and the risk of high. So in these two groups, in addition to what you have mentioned, I would like to avoid any antimetabolites altogether. If there is a possibility, please use biocollagen like Ologen, or many of these patients do well even without any antimetabolites. In some of these patients, even with the Ologen, I've seen thin cystic blebs. So that's really, really a risk which we need to consider.
Would you consider stopping steroid anti-glaucoma medication even in a planned surgery? Are we any of us doing that, believing that the bleb formation would be better? Or is it purely a theoretical discussion?
Anybody else would like to add to that? I normally don't. Practically, it's been difficult for us. Yeah. But I would prefer to discontinue some of the medications, especially prostaglandins, and probably even brimonidine. That leaves out only dorzolamide and timolol, I think. But most of these glaucoma drugs, even as early as 90s, it's been published. that they can be cause lot of morphological changes in the conjunctiva, including inflammatory cells, including lymphocytosis, which contributes to filtration failure. So ideally, it is better to stop these drugs probably 2 to 3 weeks, if feasible. I don't know how far it's practical, and substitute with oral carbonic anhydrase inhibitors. And also, if that is not feasible, at least add low-dose steroids for a couple of weeks. And there are reports that topical steroids do help in reducing filtration failure.
Dr. Craig, would you want to add something beyond all the wonderful inputs given by Dr. Krishnadas? Dr. Craig, are you
no,
there?
I think, yes, can you hear me?
Yes, yes.
Yes.
Yes. So my what I tell my fellows, I think you can always cut sutures. It's always better to leave the patient a little bit higher and to be able to manipulate and adjust the sutures. So we have a different population here, and so we often use argon laser suture lysis to manage post-operative bleb management. But I think in your particular population where you have very thick tenons, using releasable sutures is a very nice technique. And being able to place those not on the cornea side, but actually on the fornix side is ideal. It's more comfortable for patients and much easier to manipulate those sutures rather than leaving them embedded in the cornea. So that is my preference for patients that have very thick tenons, is to do a releasable suture that is tacked up on near the superior fornix.
Dr. Murli, would you take any question?
Yes, Madam, I would like to ask the panel, what is your take on doing a retrab in patients with a late failure of trab? Let's say trab has worked fine for 2 or 3 years and then it has failed. So how do you decide whether you would do a second trab or would you rather put in a tube?
Okay, so if we have a clear area and the conjunctiva is mobile over there and your initial trab has worked for quite some time and there's no other contraindication to doing a trab per se, then definitely we are doing very, very commonly a second trab before we go on to a tube. So the most important thing would be is the first trab worked for a long time? And then why has it failed? So you please see why it has failed and then try and incorporate it into your second trab. But if you have a fair enough area where you are not going too temporal or too nasal, and yet you are able to do another trab, then definitely we would prefer to do another trab.
I have a point to make.
Yes.
When you are planning a primary trab, just focus on either temporally or nasally, or slightly away from the midline, so that you have enough space for a repeat trab. So the primary trab, if somebody has done, then you cannot help it. If you are doing, or if you are planning a surgery for a patient with primary trab, then focus on having a trab slightly off from the midline, either nasally and temporally, based on your right-handed or left-handed, and then you can use those spaces for a repeat trab in that area. Those viable conjunctiva will be helpful for a future trab.
Yes, that's a wonderful information for all of us. I think we have a lot to discuss as we move further on. Dr. Satyan, please continue to stay with us. And we shall now go on to our keynote speaker, Dr. Craig Chaya, and who's going to tell us something very much more relevant to us today. He's going to be talking to us on Isent and introduction to the technology and suggestions for achieving a perfect result. And on to you, Dr. Craig.
Okay, thank you very much. Let me share my screen. Are you able to see my screen?
Yes, yes.
Okay, great. All right. Well, good evening to all of you. It's good morning here in Salt Lake City. I just want to thank you so much for the AIOC committee for inviting me to speak on this topic of trabecular bypass technology and tips on achieving optimal results. I have a few disclosures. I have served as a consultant for Ivantis, who is the originator of the Hydrus microstent, and I've done some consulting work for Allergan, which is not pertaining to this topic. So the first thing I'd like to discuss is the iStent. Many of you are excited to be using the iStent, and this is the first generation iStent that I'm showing you on this slide. This was the first MIGS device that came to market. In 2004, it was CE marked, but it took quite some time before it was FDA approved here in the United States. In 2012, it was FDA approved. As you can see, this is the original, what we call G1 or first generation device of the iStent. There are many different active parts of the iStent that I want to draw your attention to. Here is the inlet, or what we call the snorkel, and then there's also retention arches along the iStent. You can see them here in this picture diagram here, where there are 3 retention arches to help maintain the position of the iStent in Schlemm's canal. There is also a very sharp tip, the self-trephining tip, that is used to puncture through the trabecular meshwork, and then the device is slid into position. You can see the device is very small, only 1 millimeter in length, okay, with an 120 micron snorkel internal lumen, which is in this location right here. Now, this is when you receive the iStent G1, it comes in 2 different versions. There's a left version and a right version. Now, these do not determine the laterality of the iStent, but really determine the direction of delivery. So whether you are a right-handed surgeon or a left-handed surgeon, you would want to use the left or right version depending on your comfort. For me, I'm a right-handed surgeon. So traditionally, if I'm placing one stent, one iStent G1, I tend to go to the left, which is easier for my hand position. But sometimes it's important to go the other direction because maybe you can see that there's better flow patterns in that area, either based on pigment, or you can see some blood behind Schlemm's canal, or preoperative, I've identified on the limbal areas some areas where there's some aqueous collector channels and aqueous veins in order to try to target that high efficiency area. So this first generation, again, there'll be a left and right version. So depending on your hand position, you'll choose a left or right version. This is MRI conditional. What that means is that for most patients that are receiving an MRI for other issues, it is safe for 3 Teslas or less. And that's what is in the directions for use. 3 Teslas or less, it is considered MR conditional or MRI conditional. Then there is the next generation of the iStent, which came out a few years ago, called the Isent Inject. And as you can see, it's also made out of a similar material. It's heparin-coated titanium. And instead of actually placing the iStent to the left or to the right, you can actually place this perpendicular to the trabecular meshwork. And so as you can see, it's a very small stent as well, with a very small internal lumen of 80 microns. In addition, this portion has side outflow outlets, which is the head of the iStent itself. There are 4 holes with 50 microns each in diameter to help produce lateral flow. Again, this is MR conditional for 3 Teslas or less. Now we come to the newest iStent, which is called the Isent Inject. And as you can see, it's a very similar device, except it has a wider flange. And what we learned from the Isent Inject is the Isent Inject, because the original flange, I'll go back to this photograph, the original flange was very small, about 230 microns in diameter. And what we found that it was easy to deploy the device too deeply and almost past the back wall of Schlemm's canal. So some modifications were made in order to enlarge that to 360 diameters for the flange in order to prevent that deep penetration and insertion of the Isent Inject. So hence the name Isent Inject, W for the wider flange. Again, it's heparin coated and it is safe for 3 Teslas or less in MRI. Here is what the delivery system looks like. I want to draw your attention towards this first diagram here. This is the actual working portion of the device. You can see there's a sharp tip trocar inside of this barrel. And it's very important as we deploy this Isent Inject to pay attention to this trocar. And sometimes you have to turn axially the handpiece so you can see this trocar more clearly in order to make sure that you don't introduce any trocar bias, which will prevent deployment of the iStent. It is a 23 gauge sleeve, and it's a nice ergonomic handpiece. There's a retraction button here that you will slide back, and then you will press this button right here in order to deliver the iStent. The iStent Inject W comes with 2 iStents preloaded on the device, and it gives you 4 clicks in order to deploy those iStents. Unfortunately, with this iStent Inject W, after 4 clicks, if you have failed to deploy any of the iStents, it is no longer usable, and you would have to open up another one or manually insert them with a micrograsper, which would be challenging. In the new release system that will come in the future, the iStent Infinite, this will include 3 iStents on the handpiece and will include infinite deployment clicks, so that if you misfire, it's okay. You'll be able to do that again and reposition those iStents as needed. And the advantage again is that it will be unlimited clicks in order to deploy the iStent, and it will come preloaded with 3 iStents. This is just a diagram showing you that during the insertion, you'll be working out your main incision, typically your temporal incision, if you sit temporally, or you could work through a scleral tunnel, and you could also work through a superior clear corneal incision as well. Again, these devices are meant to be spread apart, anywhere from 2 to 3 clock hours, but as I'll show you in a video, it's not always possible, just maybe because of positioning or where you place the first iStent. These are my tips for optimal results, for achieving optimal results. With all of these trabecular bypass stents, it's important to have an NFOS gonio view. And what I mean by that is you want to be directly looking at the trabecular meshwork rather than looking from the top-down position where you're looking mostly at the iris and looking at the angle. You really want to be able to visualize all of your landmarks and to be able to look straight on NFOS with the gonio view. The G1 stent has a few little peculiar things about it. With the G1 stent, because you are deploying the device in a lateral direction, it's important to pierce the TM at a 15-degree upward directional control. And then with the iStent Inject W, when you're deploying the device, it's easy to use just your index finger to press the button to deploy, but by doing so, you may strum the device and cause the iStent Inject to deploy incorrectly. And so what I teach our fellows and trainees is that as you're deploying the new iStent Inject W, is you want to pretend to squeeze the entire handpiece with all of your fingers at the same time in order to prevent any bias or strumming of the shaft of the device, of the injector system. You want to gently dimple the trabecular meshwork before deploying, and again, avoid trocar bias. So this is one of my fellows performing the iStent Inject W, and we'll retract the sleeve, and then we've got good view of the trabecular meshwork. And as you can see, my trainee now is deciding which way to go. And we've decided that we were going to go initially to the left, but this is a right eye. Theoretically, there are more collector channels in the inferior nasal quadrant. So we're going to deploy here the second iStent Inject, but you can see the iStent doesn't deploy and it is still on the injector. So we'll move across and try to do it again. And remember, we only have 4 clicks. So that's now 3. We misfired twice. And finally, we're able to achieve the 4th click. You can't see it very well. It's hidden by some of the reflux of heme, but the first iStent was deployed here, and the second one was here. This is a little bit close. Ideally, we would have wanted to deploy this maybe 2 or 3 clock hours away to try to accommodate a larger surface area of targeted tissue. Okay. This is Dr. Ike Ahmed. Dr. Ike Ahmed is, many of you obviously know him, a very influential personality and surgeon in the MIG sphere. And here you can see his video on the original iStent iStent G1. Dr. Ahmed is now our director of the Glaucoma Center, or the Crandall Center for Glaucoma Innovation here at the Moran Eye Center. We're super excited about that. And here you can see the first generation G1. And as you can see, there's going to be a slight 15-degree approach. He'll use that sharp trephinating tip to engage and then level off and then slide laterally to the left. And then he will deploy, releasing from the injector. And then he'll use the injector itself to tap a little bit to make sure that it's well seated. You want to make sure that you have all retention arches covered, and the iStent snorkel should be looking almost directly at you rather than facing either down or up towards the cornea. Okay, so that is the G1. Actually, I'll go back to the video again. He's now showing you going in a different direction. As I mentioned, the iStent G1 has directionality, either going to the left or the right. This is now going to the right. Again, you slip in that self-trephiniting tip and then slide laterally. You'll see it slide into the trabecular meshwork. If you feel that the eye is moving and not deploying smoothly with the iStent, it's important to realize that that sharp tip is usually hitting the back wall of Schlemm's canal and is engaging the back wall. So you have to, in retrograde, pull it back a little bit, level off a little bit more flat, and then you'll be able to slide. This is, again, another iStent. Dr. Ahmed is placing 3 iStents. He's now using a left-handed, his left hand to deploy this iStent to the right. Again, you can see it slip just a little bit when you know you're in the right spot. Again, deploying, and then he will use the injector to tap it into position to make sure it's stable. Now viscoelastic removal just to clear the view, and there you can see very nicely 3 iStent G1s placed roughly about 2 clock hours away from each other. Okay, moving on to our next trabecular bypass stent. The Hydrus Micro stent was next to market. It was CE approved in 2017. And then FDA approved here in 2018. As you can see, it's a considerably larger device. The original G1 was 1 millimeter. This is 8 millimeters in length. It's made out of a nitinol alloy, which is a nickel titanium alloy, and it will achieve 3 clock hours or 90 degrees of treatment area. Just like the iStent, it is also MR conditional for 3 Teslas or less. This is the delivery system. It's a handpiece. It does not come in left or right versions. And the reason for that is that it has a rotating cannula that you can use to either go to the left or to the right, depending on your dominant hand position that you'll be using. There's then a tracking wheel. The tracking wheel is then used to deliver the system or deliver the Hydrus Micro stent into the canal. One very important thing is that unlike the iStent, where you can work out of your main incision, you'll have to make a separate incision for the Hydrus Micro stent, roughly 4 clock hours away from your targeted area. Here you can see this is a diagram for a right eye. And for a right eye, you want to target this area right here nasally, and you'll be making a separate paracentesis, 1 to 1.5 millimeters, approximately 4 clock hours away from the landing zone. Same thing would be for your left eye. Here are my tips for optimal results. Just like the iStent Inject, it's important to have an NFOS gonio view. Now for the Hydrus, because we're making separate incisions, I also like to label my incisions and the insertion site with a marking pen on the cornea. I think this helps in order to know where your paracentesis is under the gonio prism, and also to give you a reference mark on where you want to land with the Hydrus. You want to be in the nasal area in order to give you room for the Hydrus Micro stent to flow into Schlemm's canal. Again, you have to pierce 15 degrees upward, similar to the G1 iStent, in order to pierce through the TM. And then you really want to stabilize your hand in order to allow the injector system to hold still and not retract backwards, because doing so may actually cause the device to pull out of the trabecular meshwork. On the injector system itself, there is a curvature of the injector, and you want to reduce the gap between the back of the injector and the canal to allow it to sit flat against the canal. Unlike the Isent Inject, this is a really important tip, is to avoid overfilling with OVD, because if you tend to overpressurize the anterior chamber, you will collapse the canal and make it more difficult to actually deploy the Hydrus Micro stent properly. It'll tend to catch and it'll be very tight. Finally, it's important to verify that all 3 windows are under the trabecular meshwork to make sure the Hydrus did not prematurely exit the canal. Here's a video I'm going to show you first. Again, I'm a right-handed surgeon. I'll be using my right hand in this video. This is a separate paracentesis 4 clock hours away. And then we'll approach the TM. And this patient has a very lightly pigmented TM. Initially, you think that's the TM, but that's actually ciliary body. The darker line will be at the top of the trabecular meshwork. And I think my video got cut off a little bit, but here you can see it's deployed, and I'm now using a micro grasper in order to improve the positioning of the Hydrus microstent. It's important to make sure that the Hydrus inlet is the only portion that's uncovered. There's a transition zone that you want to make sure that is covered by the trabecular meshwork. And now we're going to be using a gonio prism here just to verify the position of the Hydrus microstent. We'll turn the eye back to coaxial view. And then this is a Ahmed gonio prism, binocular instruments in order to view where the Hydrus is. And here you can see we're looking, and you can't even see the tip of it, but there with the gonio view, you can see. I'm going to pause the video for just a moment so you can appreciate that this is the inlet and this is the transition zone. The manufacturers and the company will usually teach you to cover half of this transition zone with trabecular meshwork. I prefer to cover at least 75% of it to prevent any premature extrusion of the device. So I like to have it well seated with mainly just the inlet showing or uncovered by trabecular meshwork. We'll now show you, this is using my left hand to deploy. Again, 4 clock hours away from our landing zone in the nasal quadrant. And this view is a little bit suboptimal, but I'm rolling out the device and you'll see it very quickly roll out into position. We'll pull away carefully. And then again, we'll use a micrograsper coming through my temporal clear corneal incision in order to deliver, and then finally verifying with Ahmed gonio prism in order to verify that the stent is in position and that all 3 windows of the device are correctly deployed and covered. That's all for my talk this morning. I appreciate your time. I'm happy to facilitate or answer any questions that you may have.
Yeah, that was a wonderful presentation, which we all needed to see. But the first question is, after watching your surgery and knowing a little bit of your Hydrus, would you think that since it stents a larger area, it would be more successful than iStent in your experience?
Yeah, so there's been a publication on this already comparing the Hydrus to the first generation G1 2 iStents compared to one Hydrus. And the Hydrus was marginally improved in terms of IOP control, but it was a small study, a limited study with limited follow-up. My personal bias is that I believe that when you do target more surface area, you will achieve better results. And I think the company understands this, which is why the newest generation, the iStent Inject W, is 2 iStents on the same injector. Forthcoming will be the iStent Infinite, which will include 3 iStents to allow you to target a much larger area. So if you don't have the iStent Inject W, certainly 3 G1s may be very similar to one Hydrus. So yes, I do believe that larger surface area will lead to a better outcome and more chances that you'll actually target those high freeway access areas where the collector channels are.
Are they ever been tried in a phakic eye?
Yes, the company currently in the United States, it is not FDA approved to be done as a standalone procedure, but in many parts of the world, in Europe, Canada, these iStents and Hydrus are being used as standalone devices, whether in phakic or aphakic, or sorry, pseudophakic patients.
Dr. Murli?
Yes, Dr. Craig, I wanted to ask you, have you ever had any late dislocations of these iStent inject? I mean, anytime it has come out sometime later on?
Yes, for the iStent tends to not move. I have seen improper positioning of the iStent. We sometimes will get referrals where an iStent is malpositioned, and I've seen it into the scleral spur. I've seen it into the ciliary body, which is often very irritating for patients. And I've also seen an iStent first generation being deployed too superficially, where rather than being seated under all the layers of the trabecular meshwork, it is very superficially placed to split the trabecular meshwork. So in either of those cases, it can be repositioned easily. The hydrus is a larger device, and if properly positioned, it's very rare for that to be malpositioned if it's seated well. Now, the iStent or the hydrus can actually come out of the canal and go down through the spur or maybe dive into the ciliary body. So it's very important that as you deploy the hydrus, initially maintain that 15 degrees. And as the device comes out, then you can start to level off a little bit. The problem with the hydrus is if you turn down towards the ciliary body or the spur, it will exit the canal. And so it's very important to maintain a level position to finish the hydrus microstent. Now, I have had one case that was extruded. Actually, about 2 weeks ago, a patient that I had to take back to surgery where the hydrus was malpositioned and it had extruded. And what we discovered is that the hydrus had come out of the canal and had gone in towards the ciliary body and was malpositioned. We thought it was in the right position at the time of surgery, but in fact, it was actually prematurely, or it was incorrectly deployed halfway into the canal and then going down into the ciliary body. So that was a very difficult hydrus to remove because it's a large 8 millimeter device. I ended up causing a cyclodialysis cleft that I had to repair on the table. So it can be, it's better to reposition at the time of surgery or very early on if you're going to reposition rather than delaying that, because there is fibrosis that can occur around the device if it's deployed into the ciliary body.
Thank you very much. Yes, Dr. Harsh, you have something to ask?
Yeah, Craig, that was absolutely wonderful because we have just started doing these things. And your practical tip about how to avoid that strumming by, that was really, really wonderful for us. Two questions, because the way you just told us about the hydrus we don't have right now. So how comfortable are we with G1? We just started doing it. How much of pressure lowering can we expect with that, or should we just abandon it and go on to the inject?
Are you saying after G1, if G1 hasn't helped, would you just move on to Isent Inject W?
Yeah, W we still don't have, so we have the older version.
Yeah, so you have G1. My personal preference is if it's financially feasible for the patient, I would deploy more than one iStent. I feel that the pressure lowering with one G1 is minimal. Okay, now you may get lucky if you deploy it in just the right area where you have a superhighway, then you may get a very good result. So looking for aqueous veins, looking for areas that have high pigment might be your best zone if you can only deploy one G1. Okay, now something that I think would be useful in your situation is actually combining techniques, combining mixed techniques, maybe doing a limited goniotomy and then deploying one G1 in any direction, either to the left or to the right. And there you might achieve better results than just one G1.
Yeah, so the hydrus, the complication you just told us really scared us. So won't you think that instead of putting the hydrus, one could go ahead and do the injects? If you do 3 or 4 injects, won't it be, they'll be safer? Would you say it would be safer?
I think the Isent Inject W is certain, or even the G1, they're easy to place, relatively easy. I think with practice, the hydrus, here's why I like the hydrus. I'm biased towards the hydrus because the device tends to not only bypass the TM, it tends to scaffold and hold open that 90 degrees. And so that's why I think you get better pressure lowering. Whereas an Isent Inject, you're really just bypassing the trabecular meshwork, and you are maybe scaffolding a little bit in that area, but not nearly as much as you can with the hydrus. So I do think that with time and experience, you can avoid some of the complications that you see with the hydrus, and really maintaining that 15 degrees, reducing the gap from the injector. And one of the things that I commonly do now, I will say probably 90% of my hydruses are done in conjunction with viscodilation. And that's done with an iTrack catheter. You can also do it with an Omni system. There are other systems being developed right now in order to viscodilate Schlemm's canal. When you dilate Schlemm's canal with viscoelastic, it makes it very easy to place the hydrus. It will slide in very easily when you expand the canal with viscoelastic. So I think that will be one thing to look forward to, is if there's a system that can be developed, either just with a small cannula to inexpensively dilate the canal prior to hydrus insertion. I think you can look forward to that as a potential option. But right now, yes, if you are trying to achieve the same results with a G1 compared to Hydrus, you may have to deploy more than one.
Thank you.
Thank you. So we shall, thank you very much, Dr. Craig. I think you may not be able to stay for long, but we look forward to you adding your very wise comments through the course of the webinar, if you can keep your laptop on while the OPD is running. So
okay, I'll be driving to OPD now, so I'll try to listen. But thank you so much for the invitation, and have a good evening, all of you.
Thank you. Thank you. We shall now go on to our next speaker, Dr. Sirisha Sendil, who heads the glaucoma department at the LV Prasad Eye Hospital and a specialist in cataract, glaucoma, and children's eye care. And we all know she's a very eminent glaucomatologist of our country with her own set accolades and awards. And she is going to take us to a very challenging talk, a consensus on glaucoma management and Sturge-Weber syndrome. On to you, Dr. Sirisha.
Thank you, Dr. Chitra. It's been wonderful listening to the two previous talks. So let's change gear from minimally invasive to the most difficult condition that we tend to manage. So the objectives of the presentation will be what is it that is different in Sturge-Weber's syndrome and glaucoma? How do we manage them? And the modifications that we do to have a safe surgery and the consensus that we have in dealing with this disease. So not getting into too many details, but to brief everybody that Sturge-Weber syndrome is a type of phakomatosis with an encephalotrigeminal angiomatosis, which means that there is involvement of the facial cutaneous vasculature. There is involvement of the hemangiomas involving the first and the second division of the trigeminal nerve. There is also leptomeningeal involvement, which causes seizures and secondary systemic involvement as well. So we are dealing with a condition where there is systemic abnormalities, and some of them may have mental retardation and seizures that again one needs to be careful before we take it up for surgery. Ocular involvement can have hemangiomas of the upper lid, lower lid, of the episclera ciliary body, and most commonly what we see is choroidal hemangiomas. So the glaucoma in this condition is very difficult to treat. They usually present as two peaks. First of them will present at very early age. That means they can present even with congenital glaucoma. A newborn baby can have glaucoma with Sturge-Weber's or with phacomatosis pigmentovascularis. The second peak usually arises in a little early adulthood, or maybe I would say children in teenage, where that is likely because of the raised episcleral venous pressure. In a baby, if it presents, usually it is because of the maldevelopment of the trabecular outflow pathways. So the time of presentation is very important, because depending on when it presents and what the mechanism is, our treatment would vary. So episcleral hemangioma, you can see a picture here, very beautiful network of blood vessels that you see when we open up the conjunctiva in these patients. That is episcleral hemangioma, and that actually poses a lot of problems for us when we operate them. Choroidal hemangioma, very difficult to identify unless we examine both the eyes of the patient, especially if it is unilateral. You will just see an orangish hue and nothing different. So it's important to identify, because this is again very important, because intraoperatively as well as postoperatively, one may expect complications, much more complications in patients with hemangiomas. So this is just a bright red glow in an eye that is with a pupil dilated in a child with Sturge-Weber syndrome, which possibly gives you a hint that there is a choroidal hemangioma. So often we ask this question, do medications help? Like any other disease, when there is an early presentation, medical treatment does not help, and it is a surgical disease. Like I said, most often the angle is dysgenetic if the child is small, and that requires a surgery. And if in older children, when they're present, medications definitely have a role to play. What medications do we use? We use in children, depending upon when they're present, we use timolol or a beta blocker, a dorzolamide, or a combination of the same. But in this particular condition, because the problem here is possibly secondary to raised episcleral venous pressure, a mechanism that will bypass the raised episcleral venous pressure that does not depend upon the trabecular outflow possibly is more helpful, which means that a PG analog group of drug may be more helpful in these patients compared to the other group of drugs, where especially the trabecular outflow pathway, if you can try and avoid. But when we are desperate, we try and give them all medication. So there's nothing wrong in using them, but it's just to know which of them, if you have a choice of using one medication, maybe a PG analog would be more helpful. Often we require surgery to control intraocular pressure in these eyes, but if I have a child, especially not a baby who presents with glaucoma, it's easier to handle because this eye is not exposed to high pressures for a long time. However, if you have a patient who's older, in their teenagers, who presents with glaucoma, more often they present with very advanced glaucoma. These are extremely difficult to treat, and majority of us try and defer and try to use as many medications as possible to control the intraocular pressure. There are various surgical options that are there. I can possibly take you through a few of them with the tips. So why is it is so difficult to operate these patients? So surgically, I don't think there is much of a difference, except that these eyes can bleed a lot, they can have hemangiomas and things like that. But the other major problems that we are worried about is causing a decompression, because the choroidal hemangioma, episcleral hemangioma, these are all hemangiomas where there is increased blood supply to the eye ocular structures. So whenever we cause a decompression and hypotony, that causes that predisposes these eyes to extensive choroidal effusion and exudative retinal detachment. Shallow anterior chamber, flat anterior chamber is a very common problem, and intraoperative expulsive or a suprachoroidal hemorrhage is again not uncommon. That apart, because of extensive vascularity, there is a high risk of surgical failure irrespective of which surgery that we perform. So just sharing a few case examples to know what kind of problems we are likely to get and how do we handle them. This is a boy who presented with a left-sided port-wine stain with unilateral glaucoma, and pressures were well controlled until this age when his pressures went uncontrolled and he required a surgery. So preoperatively, we did do evaluation including the OCT. The choroidal volume was really huge and baby had a diffuse choroidal hemangioma. So we did a trabeculectomy with mitomycin C surgically with all precautions that one can take. So most importantly, we were worried about a choroidal detachment. Fortunately, he did not have that. But what happened on day 3, suddenly there was decrease in vision. So what he had around 20/40 suddenly decreased to almost about 2 meters, 3 meters. That is because he had a huge serous macular detachment. So not necessarily that they have a choroidal detachment, they can also present with a vague picture of a serous macular detachment that can suddenly bring down the intraocular, bring down the vision, and that can be very dramatic. So this child was put on oral propranolol, and soon it resolved by about a month. So this was the kind of submacular fluid with a retinal elevation. In about 4 weeks' time, he completely resolved. So it is possible to treat, but what we need to know is reassure the parents that such a thing can happen, but also keep a watch on that. So when there is a drop in vision, make sure that you examine the retina appropriately, otherwise get an OCT done to understand if we are dealing with that condition. And it completely resolved, and his vision came back to 20/40 and he was doing fine. One of the associations that we deal with in Sturge-Weber's is a bilateral involvement and a condition called as phacomatosis pigmentovascularis, where there is also a pigmented component apart from the hemangioma that they have. It's one of the most difficult glaucomas to treat, and unfortunately they present bilaterally and the glaucomas can be very difficult. So this was a boy with this condition, and so what I normally do is preoperative propranolol 2 weeks prior to surgery, huge episcleral hemangiomas. So what we need to worry about is a lot of bleeding intraoperatively. So the good dissection, a careful dissection, a good cautery to the episcleral hemangiomas, pre-placed sutures, and maybe additional sutures to make sure that you're not dealing with hypotony on table, and always make sure that the anterior chamber is kept formed either with viscoelastic or with air, whatever suits you, and make sure that there is no intraoperative hypotony. Some people also use a anterior chamber maintainer to prevent the hypotony during surgery. So whatever suits you is fine, but I think it's very, very important. So with all the adequate precautions that we took, this was the day when post-op, AC was shallow, air bubble that I had left, part of it got absorbed, but these are problems that we know will occur. But what is worrisome is this kind of exudative choroidal detachment. This gentleman was started on oral propranolol 2 weeks prior to the surgery, but this was the kind of extensive choroidal detachment with exudative retinal detachment with vision which dropped to hand motions from 20/60 or 20/80 that he had. So you don't have to worry. continue the medications, and you can actually see this slowly resolving, and even the submacular fluid resolving, and vision by about 6 weeks improved to 21/25, and his vision was about 20/60, 20/80 prior to surgery, and pressure slowly started going up. And I'm happy when the pressure went up, because that little bit of CD and the exudative RD that is there also will disappear maybe in a few weeks time. Repeat interventions is something that we have to be careful about, and they are more prone to having complications in these patients. So this, like I said, phacomatous pigmentovascularis is very, very difficult to treat, and most often the first surgery fails and one may end up needing to do an implant. Again, one can ask this question, is implant better than performing a trabeculectomy? We'll come to that in a little while. So what is necessary is taking a preoperative precautions, doing a careful evaluation, intraoperative modifications for the surgery, as well as post-operative medications and follow-up as and when necessary, I think will go a long way in preventing complications in these eyes. So the surgery that we prefer in early onset glaucoma is a combined trabeculotomy with trabeculectomy. We have shown results that are good over a period of about 64 months. Very minimal chances of complications in these eyes, but yes, we need to be careful as these children have a problem at a very early age. As time goes by, they may require additional surgeries in the future as well. GDDs, I don't offer it as a first line procedure. We still prefer to do a trabeculectomy as the first line. The GDDs do have a role to play in reducing the intraocular pressure. This is a cohort of patients that were published from Sharon Friedman's group, where they also have performed it as a majority of them as a repeat intervention. So what is most important to understand is even with GDD, the complication rates are quite high. Close to 50% of the eyes had complications. So when somebody asks your trab is likely to fail, it's likely to fail, not necessarily in all patients, but we also have to worry about the problems, or so the GDD not necessarily are safer compared to trabeculectomy. So safety wise, I think all of them, any surgery that causes a decompression can have problems, but we need to handle them. TSCPC may be used in certain conditions, but we don't do that in a seeing eye. One question that is commonly asked, a question that I have asked myself, do you do your prophylactic sclerectomy in these eyes? Like the non-ophthalmos, I don't do it. There are results to studies that have shown the presence of absence of sclerostomy does not result in excess complications, but there's no RCT for us to really say whether it is helpful or harmful. Propranolol, I think this study from Sushmita's group has been a really landmark paper that has helped us to actually handle these patients with definitely with a little bit more confidence. And so what they have shown also is that oral propranolol is helpful in preventing, or rather helpful in resolving the condition when they have a CD post-operatively. Bilateral cases, repeat interventions are definitely at high risk of developing complications, which may require an intervention. So how does propranolol help? It actually causes a vasoconstriction. So there is a review that had looked at the types of surgeries and to say, is one surgery better than the other? Trabeculectomy and valve implant almost have similar results. However, we need to worry about the complications in these groups. Recently, there was a paper that was published in BJO from a group in Bangladesh. Fantastic results they had shown. In fact, they were too good to believe. And their complication rates were very, very minimal. But remember, these were older patients, like in their 4th decade, which they have managed. But I do not know whether, this kind of results, maybe because they didn't have that severe a glaucoma until their 4th decade, whether they were responding better. But in our hands, our complication rates are definitely higher, although we can handle them better. To sum up, high risk of glaucoma in patients with Sturge-Weber's, medications definitely have a role to play, but in older children. There are problems with surgery, but modifications are definitely helpful to offer a safe surgery in these patients. And even if complications do occur, I think what is important is to recognize them early, the type of complications that they can develop, and treat them appropriately. A bilateral condition, second intervention definitely have high risk of complications. And there's a very limited role of possible prophylactic sclerectomy in these patients. And oral propranolol definitely is helpful to handle the choroidal detachment and exudative RD that they develop in a conservative way. Thank you so much for your attention.
Thank you so much, Dr. Shirisha. That was a truly wonderful talk. But continuing it content, since there are two concepts, the angle dysgenesis and the increased episcleral venous pressure, would you think angle surgeries do also have a role to play?
Yeah, so because of the time constraint, I really did not go into the details because we don't perform angle surgeries in these patients. So if we do angle surgery, we do it as a combination by doing a trabeculotomy and trabeculectomy in a young baby where even angle dysgenesis is likely to happen. But so avoiding the trabecular outflow or bypassing the trabecular outflow would be a preference, and angle surgeries don't show good promise in these patients.
Would you, if you were to use a GDD, would you think of narrowing the lumen?
Not really. That's what I was saying. So whether we use a valved implant or we use a non-valved implant with a fenestration or a very slow decompression, when the decompression happens, even if it means it's a minimal decompression, patients are likely to have a complication. So it could be less, it could be more, but yes, any of these interventions can cause a problem. In fact, a couple of situations where an AGV with a tube ligation is also something that we have done. But even when that ligature dissolves, you will have a decompression. So these eyes are more prone. That's what I think we need to remember. But at the same time, I don't think we should really worry about losing the eye. Fortunately and thankfully, we haven't lost any eyes. Yes, we may lose 1 or 2 lines of vision because of the problems that they deal with, that they have. But if we handle them appropriately, we may not lose vision because of the surgery.
Dr. Murli?
Yeah, madam, what is the dose of propranolol that you typically use?
2 milligram per kg body weight.
And would you recommend a limbus-based flap in these patients for a tighter closure, or is phonics also okay? Phonics-based flap also?
Yeah, so in children, majority of the time, I do a limbal based, and also in complex eyes, I do a limbal based, because even a little bit of leak, a chance of a leak is something that you really don't want, and multiple sutures are releasable. So, I mean, it's a personal choice. Many people prefer to do a phonics based with tight anterior conjunctival closure, but I think that's a surgeon's choice.
Thank you. Paucity of time, I think we have to move on, although this is something lot to learn, as these cases have a very challenging post-operative period. So we go on to next speaker, Dr. George Putran, who is again Chief of Glaucoma Services located at Arvind Eye Care Systems of Madurai. And of course, we all know that he's an amazingly prolific surgeon with a lot of innovative skill sets with him. And he is going to be telling us something more interesting, glaucoma surgery and tiny tots and the guidelines on the choice of surgical procedure and how to do a safe surgery. On to you, Dr. George.
Thank you very much, Chitra ma'am. And surgery is a critical component of the management of childhood glaucoma. It is important to prepare patients and parents or caregivers for lifelong follow-up and possible future surgeries. Glaucoma surgery should preferably be performed by a trained surgeon in centers where there is sufficient volume to ensure surgical experience and skill and safe anesthesia. So a lack of familiarity with the ophthalmic eyes is associated with more complications. Children generally have lower surgical success than adults, except for angle surgery where the opposite is true. An aggressive inflammatory and healing response in children is thought to account for this fact. Lastly, lack of cooperation affects the degree of monitoring and post-op follow-up, which can compromise surgical results. There are a number of surgical procedures to choose from, with varying indications as well as advantages and disadvantages. Angle surgery, goniotomy, trabeculotomy, conventional and circumferential, combined trabeculotomy with mitomycin, and aqueous drainage implants. There are very few randomized surgical trials in childhood glaucoma, and in the absence of these trials, consensus becomes very important. I have included in this presentation perspectives from the Worldwide Childhood Glaucoma Surgical Survey conducted by the World Glaucoma Association. This survey is the largest ever worldwide survey of childhood glaucoma experts who manage between them a considerable number of patients with childhood glaucoma. This data provides an informative and important glimpse of practices among childhood glaucoma surgeons. Goniotomy was selected as the procedure of choice for primary congenital glaucoma by 28% of experts. Trabeculotomy was selected as the procedure of choice for primary congenital glaucoma by 41% of experts, with 28% of them preferred the conventional probe technique and 13% the circumferential trabeculotomy. Combined trabeculotomy was selected as a procedure for treating PCG by 14% of experts. I am by now totally convinced that the first operation has the greatest chance of success, especially in primary congenital glaucoma. Whichever operation is chosen, the technique must be safe and it must be one that works in your hands for your population. Angle surgery is the procedure of choice for primary congenital glaucoma with the exact choice dictated by the corneal clarity and the surgeon's experience and preference. So goniotomy in PCG, if cornea allows satisfactory visualization of the angle, most effective between 3 and 12 months of age, and the obvious advantage that it does not violate conjunctiva and prejudice success of future surgery. A conventional 90-degree to 110-degree probe trabeculotomy is the initial procedure of choice in our cohort of children with PCG. The advantage of trabeculotomy is that it could be used in all cases of glaucoma in children, regardless of corneal clarity. So accurate localization of the Schlemm's canal is the key. A partial thickness scleral flap is fashioned, and Schlemm's canal is located under high magnification by slowly and carefully deepening while spreading the incision walls of a small radial incision at the limbus near the gray zone. Successful entry into the Schlemm's canal is often accompanied by a reflex of blood and or aqueous from the cut edge of the canal. A Harm's trabeculotome is gently inserted along the course of the canal, and when completely inserted, the probe is rotated towards the anterior chamber, breaking through the remaining trabecular tissue with virtually no resistance. The greatest challenge of the procedure is to correctly identify the Schlemm's canal. The canal is found in the corneoscleral sulcus at the blue-gray-white transition between the scleral and the corneal tissue. Using high magnification, a cellulose sponge can dry the junction and allow for the appreciation of droplets of clear aqueous bleeding precisely above the canal. A radial incision 2 millimeters its length is made at that point. If the surgeon is unsure of the landmarks, it is possible to extend and deepen the posterior end of the radial incision until the choroid is seen. Carrying the incision anteriorly from that point allows the surgeon to see the scleral spur, and the canal is just in front of the spur. An alternative to the traditional metal trabeculotome approach, which incises up to 1/3 of the Schlemm's canal, is to use a blunted suture like a 6-Uroprolene or an illuminated microcatheter to incise 360 degrees. Circumferential trabeculotomy is advocated and is becoming increasingly popular as the entire angle is treated in one session and surgery therefore does not have to be repeated. CTT, combined trabeculotomy is argued to be more successful than either procedure performed alone, although there are no prospective comparisons to support this assertion. CTT has been associated as a primary procedure of choice in populations which are thought to be at greater risk of failure because of more severe or advanced presentation, such as in the Middle East and India. Glaucoma drainage device surgery is an important part of therapeutic repertoire in childhood glaucoma, especially in failed angle surgery or as the first surgical procedure in certain secondary childhood glaucomas. GTT surgery was the preferred primary operation chosen by 44% of experts following removal of childhood cataract, whereas after failed angle surgery, 53% of experts preferred it as the next surgical option. There are certain clinical scenarios, like in this tiny tot with a 15mm cornea, refractory glaucoma post-failed angle surgery, where we will need to risk an aqueous drainage implant. And in our constant endeavor to make tube surgery safe even in the very young, we have found that embedding the tube in the patient's own sclera minimizes the otherwise dreaded complications of tube exposures, extrusions, and endophthalmitis. A caveat is to have a needle-generated scleral tract of sufficient depth and length so that the tube is buried well inside the scleral tissue. There is an intimate relationship between corneal pathology and glaucoma in childhood glaucoma. As corneal clarity is profoundly affected by IOP, reducing IOP before turning to cornea surgery is advocated. Successful glaucoma surgery may eliminate or delay the need for corneal grafting. If corneal surgery is contemplated, IOP should be addressed first. To conclude,
1 minute remaining, sir.
Yeah, surgery is the mainstay of treatment for childhood glaucoma, is most challenging and is inevitable in the child's lifetime. Just as there is variation in the way children can present with glaucoma, there is also variation in the approach to surgical treatment. Considering that multiple surgical interventions are likely, whatever the approach, the need for long-term surgical strategy and algorithm of action is essential. Surgeons need to modify and develop a technique that is safe and works in the surgeon's hands in order to balance increased success with decreased complications. Thank you once again for the opportunity.
Thank you very much, Dr. George. It was an amazing talk. And I'm going to ask our pediatric ophthalmologist, Dr. Murli, to take one question, because I think we have a number of speakers ahead. We have to move faster. Dr. Murli.
Dr. George, what is your tonometer of choice for these kids? Do you use the rebound tonometer?
Murli, I didn't get you.
No, what is the tonometer of choice for these kids, sir? I mean,
yeah, we now use eye care, Murli.
Okay, and if the corneal diameter is more than 14, should we still try the angle surgery or should we straight ahead go for trab?
I would still try. If it's the first procedure of choice, even with a 14mm cornea, I would still try a Travicolotomy first, Murli, before. What did you say before? Before we go for a
trab?
No, I would prefer to try a Travicolotomy first.
Okay.
Thank you very much, Dr. George. We shall now go on to our next speaker, Dr. Sunita Dubey, who again heads the glaucoma clinic at the Schroff Eye Charity Center and is again a very dynamic surgeon. And she is going to tell us something even more curious and not too common, the persistent bugbear, aniridia and other angle segment dysgenesis. On to you, Dr. Sunita.
Thank you, Dr. Chitra. I'll be sharing my screen. Okay, so I'll be mainly talking about aniridia because it's not possible to cover everything in 8 minutes. So congenital aniridia is a rare genetic disorder. It is bilateral and with variable expressibility and variable degree of hypoplasia or absence of iris. It is predominantly because of the PAC6 gene mutation, and since PAC6 is expressed in the cornea, lens, iris, and retina, mutation can result in a pan-ocular condition affecting anterior as well as posterior segment structures. Other genes involved are FOXY1, PITX2, SIP1, etc. And when FOXY1 and PITX2 are involved, there can be a combination of aniridia with Axenfeld-Rieger syndrome with associated systemic anomalies like dental anomalies, heart problems, or umbilical hernias. And SIP1B1 may present with glaucoma at birth. Glaucoma and aniridia occurs in approximately 46 to 70% of the cases. 2/3 of all aniridic cases due to PAX6 mutation are familial, displaying autosomal dominant inheritance, and the remaining 1/3 are sporadic and non-familial because of the de novo gene mutations or deletions, and sporadic deletions of PAX6 contiguous with WT1 gene can result in Weger syndrome, which is Bill's tumor, aniridia, genitourinary abnormality, and mental retardation. So the patients with Weger syndrome need to be monitored on a continuous basis, at least for a defined period, at least till 10 years of age, and ultrasonography of the abdomen should be done to rule out Bill's tumor. A small percentage can be autosomal recessive, which is associated with some syndromes. So as far as the ocular spectrum of classical aniridia is concerned, there is complete absence of iris, and there is presence of the spanness or absence of a well-defined demarcated limbus, and which can progress to aniridic keratopathy. Then other very common features are foveal hypoplasia, optic nerve hypoplasia may be there, cataract, ectopia lentis, nystagmus, MGD, and microcornea. So this is a table showing prevalence of various findings, and as you can see that aniridia in aniridic children, reduced visual acuity and high-risk hypoplasia are present in 100% of the patients, and the other common features like cataract, foveal hypoplasia are also very common. The systemic associations like Weger syndrome, Gillespie syndrome, auditory deficits, diabetes, and pineal gland hypoplasia may also be there. Aniridia-associated keratopathy is one of the earliest signs to be there, and it initially presents as a circumferential and peripheral opacification of the epithelium and subepithelial layers, with vessels advancing into these areas from the limbus. And over a period of years, this spannus extends centripetally and eventually opacifying the entire cornea. It's very important to know the grading of this aniridic associated keratopathy, and to begin with, in stage 1, when you do not see very obvious findings, fluorescence staining should be done, and it will be manifested as increased uptake of fluorescence both in the conjunctiva as well as cornea. And it's important to treat the patient at this stage with a lot of lubrication, cyclosporin, and maybe autologous syrup to prevent progression of the keratopathy to some extent. Cataract is again very common, and 50 to 85% of the patients usually during the first 2 decades of life develop cataract, and in later stages it may subluxate superiorly. Glaucoma associated with aniridia doesn't present so often at birth, although defective iris is apparent at birth, and it develops in late childhood or early adulthood. And infantile cases are obviously because of the trabeculodystogenetic anomaly. However, the late onset glaucoma, it is mainly the anterior stroma of iris which sweeps over the trabecular meshwork, and you can see the absence of Schlemm's canal or abnormality of TM, and development of synechia or ridges between the iris stump and the angled wall, which the anterior rotation of the iris stump leading to complete closure of angle. First line of therapy is the medical therapy, and then there are various surgical options. Prophylactically, one can perform goniotomy, and Dr. Walton has a large series wherein it was very successful before development of glaucoma. TRAP plus TRAP with mitomycin C gives variable results. However, it's important to perform a limbal-based conjunctival flap because there is a limbal deficiency of stem cells, and also it's important to prevent shallow ACN hypotony immediately post-operative because it can be disastrous. There is no iris barrier, and there can be direct touch of the lens to the cornea. So releasable sutures are preferred and try to prevent hypotony post-operatively. TRAP plus TRAP if aniridia is associated with congenital glaucoma, and GDDs are preferred options, especially in cases with scar tissue at the limbal area, and cyclodestructive process as the last resort. So Dr. has already shown this procedure. So in this particular patient who was having aniridia with congenital glaucoma, I performed goniotomy as well as trabeculotomy in this patient, and the media was hazy. The view was not very clear, and so the rectangular scleral flap was made and was dissected into the till the limbus, and radial incision is made over the Schlemm's canal, and then with the Harm's trabeculotomy, the trabecular incision is performed by entering through the Schlemm's canal on either side, and then the suturing, conjunctival suturing. So I would like to discuss 2 or 3 cases. This was a 2-month-old child who was brought to me in 2009, and he was diagnosed to have congenital glaucoma with buophthalmos in both eyes. And on examination, the corneal diameter was slightly higher in the left eye, 13 millimeter, right eye was 11. And the IOP was also high. There was aniridia, cornea was hazy. Trap plus trap was done in this particular patient in 2009. And he had a very good follow-up with me. And till 2017, his pressures were maintained. However, in 2018, he developed this cataract in the right eye and left eye superior-nasally subluxated lens. So he underwent cataract surgery and then membranectomy, and the pressure became very high in the right eye, and eventually he underwent ADI implant. So the surgery controlled the pressure, but as you can see in 2019 and 2021, there was progression of keratopathy. So these are progressive cases, and if there is keratopathy and if there is progression, then you expect PAC6 mutation. This is the IOP which was controlled after ADI implant also. Another patient, both eyes aniridia with subluxated lens and grade 2 keratopathy in both eyes. And trap plus trap was done in both eyes in 19 and 20. And the trap with trap is working really well, and she has been under control for 3 years. This is the last case. The patient presented to us at the age of 4 months, and he had microcornea with partial aniridia and cataract in the right eye with epithelial edema, and in the left eye, total aniridia with lens luxation. So he underwent trap plus trap followed by lens aspiration in the right eye. Left eye, he developed RD in 2021, and for which he VR surgery with lensectomy and oil retention sutures. However, after silicone oil removal, the pressure went very high, and eventually he underwent GDT implantation, and right now he is doing well with the well control. So associated glaucoma is really difficult to manage and often refractory to medical and some of the surgical treatment. Outcomes are better if diagnosed and managed early when there is not much changes. And long-term follow-up is required for these children, and close compliance and follow-up is needed to improve prognosis. Thank you very much for your kind attention.
Thank you very much, Dr. Sunita. I would ask just one question to you. When would you take a decision to do a goniotomy? When would you do a trab? When would you do a tube if a patient comes with high intraocular pressure in these cases?
In aniridia?
Yes.
So aniridia, actually goniotomy is not very successful when it is not successful as a therapeutic procedure. It is successful as a prophylaxis, but we are not doing as a prophylactic procedure. Dr. Walton has a very big series, and if it is associated with congenital glaucoma, first surgery of choice is trap plus trap with mitomycin C. And if the child presents late, so still first surgery of choice for me is trabeculectomy, even if the child presents later in the early adulthood or late childhood. And if the trabeculectomy fails, then I would go for tube implant. So in aniridia also, I first like to do trabeculectomy with mitomycin C or trap plus trap, depending on when the child is presenting.
Thank you. Murli, you have anything to ask before we go on to the next talk?
Yes, madam. What is the dose of mitomycin that you use for these patients when you do a trabeculectomy? I mean, do you use a higher dose or injectable or
Yeah,
anything?
children, the difference is that one can use 0.4 milligram per ml. And in children, I tend to use both subconjunctivally and substerally, as opposed to adults wherein I use subconjunctivally mostly. So, and for 2 minutes only. I don't increase the duration.
Okay, thank you very much. Dr. Ratni, has she joined? Dr.
Yes,
Ratni?
ma'am. I'm here, ma'am.
Is Dr. Vijaya not joining in? Have any idea?
I think she's held up in some other commitment, ma'am.
Oh, so the thing is, no, her talk is a very important talk. Dr. Krishna Das, Dr. Harsh, I think I would take some questions with you all, myself and Murli, so that we cover the talk, and in case she's able to join, we can again take her talk. That's okay with you all? Dr. Ratni, I would
Yes, ma'am.
to show your screen sharing. I
Yes,
mainly
ma'am.
called you because I want to know about
Sure,
Dr.
ma'am.
Vijaya. So Dr. Vijaya's talk is how to get a perfect bleb and good IOP control in trabeculectomy while giving complications a mess. I think that's an extremely very important topic. So let me take some questions with you all. We'll start off with something quite basic. Dr. Krishna Das, are you there with us?
Yes.
Yeah. So how do we gauge the extent of punching and anything relevant you would have to tell us in that to make it a very safe surgery?
Yes. Most of the punching, I think with the Kellys, it is pre-calibrated. So it's available as 0.75 square millimeter, 1.25 square millimeter like that. But the most important is ensuring that the sclerostomy is placed centrally under the scleral flap so that it doesn't overwrite the scleral edges. In fact, there is a possibility, intentionally it can be actually placed over one or the other with notes made in the medical records, so that this suture adjoining the sclerostomy closer to the scleral flap edge can be preferentially be lysed to allow more filtration to occur. I do not practice this, but this is one of the recommendations that has been done by some experts. But I normally place it well centrally under the scleral flap, equidistant from either of the scleral flap edges, so that the chances for overfiltration is minimal.
I think it's also important we make the punch where the white meets blue, because if it is too posterior, you could have an iris prolapse, and if it's too anterior, you could have that valvular effect. So I think that's another important point also. And if you ever to at all use a keratome, you should not enter full width. One question to you, Dr. Harsh. How would you minimize the incidence of conjunctival leaks?
Yeah, so initially I used to do all limbal-based flaps. That's how Ramanjeetan had taught us. And that they are really, really safe as far as the leak part is concerned. But yes, the amount of fibrosis was quite a bit. So we moved on to the fornix-based flap. Now in the fornix-based flap, so what we are doing is we are giving 2 wing sutures that I initially used to give, but still there would be leaks. So we have now moved on to giving 2 mattress sutures by 10O. So that way you make it completely tight. So there's no way any leak is going to occur. Yes, some will still occur, and if you detect early leak, you can give either a bandage or a bandage contact lens, which really works wonderfully over there. And the leak, the internal leak, again, I have gone on to do a complete tight flap sutures, because many of our patients are one-eyed patients, and we just cannot have a situation where there is a diffuse drainage and choroidals and things like that in these situations. So I would rather do a tight flap thing and then release the sutures, or we do the laser suturolysis one by one and gradually do it. And yes, we have been, when we make the internal flap, we make it anteriorly, then we reflect it back And the moment you see the pigmented line, you go a little behind that to give the cut so that you know that the either end of the Schlemm's canals have been opened up over there while you are taking the internal flap.
So you believe in putting 2 to 3 releasable sutures, but putting number of sutures, right?
Yeah, absolutely. We only put one because mostly we are doing suturolysis and we are able to do a laser suturolysis most.
Okay, Dr. Krishnadas, your thoughts about the suture part of it? You have to unmute yourself, Dr. Krishnadas.
Sorry, my personal preference is triangular flap with a single fixed apical suture and 2 releasables. And I would like to release the sutures as early as possible, probably within 10 days. Later than that, it's very difficult to release these sutures. And another thing, this is as far as most open angle glaucomas is concerned. In angle closure glaucomas, we don't want any even minimal overfiltration to occur. So in angle closure, I prefer fixed sutures and try to delay, if at all it is necessary, I try to delay laser suture lysis as much as possible. In fact, I would like to start the aqueous suppressants if the bleb is fibrosing earlier than going in for suture lysis of bleb need.
Okay.
This is because even minor chances of overfiltration can cause choroidal effusions and flat chamber in angle closure.
Okay. Murli, can you take one more question on the intra-op before we go on to the post-op questions?
Yeah. I would like to ask the panel about their policy on doing a clear lens extraction or cataract surgery with very early cataracts in patients with angle closure glaucoma, combined phacotrabeculectomy in these cases, or would the panel still stick to a trabeculectomy, especially if the anterior chamber is very shallow?
Can we have the responses from some of the speakers?
Yes, sure. Dr. Sushmita?
So, good evening, everyone. Good to be here.
I know it is not allowed to have you stay quiet for so long. Just wrong on our part.
No, interestingly, with very shallow ACs and early cataracts, I've actually started taking out the early cataracts and combining a bang. And that seems to work very well, including primary angle closure. But I was very skeptical. But if we just put in visco and we strip off a bit of the trabecular meshwork, bang along with cataract surgery has almost become my mantra now for both open and angle closures. But if the angle closure is only a moderate glaucoma controlled on 1 or 2 drugs and there is early cataract surgery, I wouldn't think early cataract, I wouldn't think of a trap. I would think of taking out the cataract first, and many times that's all that's required. But phaco trap has become really low on our, with somebody who's come with 1 eye, 40 pressures, we require a trabeculectomy and the person has a cataract. That's my indication for a phaco trap.
Oh, okay. What do you think about the wound modulating agents in the post-operative period, Dr. Sushmita, like when you want to minimize the chances of bleb failure? Just briefly, how would you handle it?
We use a lot of 5-fluorouracil, 5 milligram per 0.1 cc. It comes in the bottles as it is, 250 milligram and 5 milligram or 500 milligram and 10 ml. So we just need to take 0.1 cc of whatever comes. Usually it's not before the first week, especially since we're using mitomycin. But if we see corkscrewing or if we see excessive vascularity, regardless of the intraocular pressure, that's something that we teach, that IOP has nothing to do with injection of anti-modulation. But anytime after the first week, and maybe 2 or 3 times is required in the first 6 weeks if required, but completely depending on what the patient has.
And would you believe in stepping up the topical steroid drops, or would you also think of early releasable suture when there's a bleb failure? What else would you combine along with it?
So releasable suture would be dependent upon the pressures and not just the blebs. So I might have pressures which are 12, but if I see a very vascular bleb or I see it starting to wall around, then I would think of going in with a 5FU. And releasable sutures depends on whether the pressure is high or not. So I would want to increase filtration only then.
what is your endpoint of giving a 5-FU? Like how many injections would you consider giving and when would you stop giving?
No, I don't think.
The Bleb is actually very angry looking.
Yeah, I don't think if it's more than 6 to 8 weeks after surgery,
yes,
I think we need to do something more drastic. We need to think of something else.
Yes.
Another thing is we are now, instead of doing revisions in the conventional sense, we are doing it ab interno. So we don't disturb the conjunctiva, and that works. But then within the 3 months, even the needling works well at the slit lap. So depending on the Bleb, I mean, we need to nurture it as it comes.
Okay, Murli?
Yes, madam. Sometimes the releasable suture breaks when you remove, especially if you remove it in the 2nd or 3rd week. So what should we do? I mean, should we attempt a laser suturolysis in this patient?
Yes, if I need to remove the suture, I'll have to do a laser suturolysis. But I'll confess that before we had the Hoskins lens, I also dared take a 27 gauge needle away from the Bleb and go in. And if usually it's visible and you just cut it. And
yes.
You can do that manually.
Yes.
But that's not a nice thing to do, but I confess we did that.
Yeah,
and it worked.
yeah, sure. I think it's not. Dr. Krishnadas, have you ever tried doing that?
No, Dr. Chitra.
And
you can actually take the edge of the gonioscope, sometimes press it over there and blanch it with this thing. Phenylephrine.
Yes, for suture lysis we do that.
Yeah. And how would you manage a weeping Bleb in an early post-operative? Any of the panel, and also Dr. Shushmita, anybody else also could answer.
Sorry, a leaky Bleb?
Weeping Bleb in the early post-operative period.
Okay. Well, what I've seen, a VP Bleb is usually later. It's usually seen at times when we used to use mitomycin nearer the limbus rather than the fornix. And it's later in the course. It's, a thin cystic Bleb which then starts to weep. But early post-op period is usually leaky. And if there's a leak, it has to be repaired. Maybe a pinpoint leak, I would hazard a bandage contact lens for maybe a day or two. But if it doesn't settle, I wouldn't wait too long.
Yes. Murli, some questions? Actually, Dr. Krishnadas, Dr. Harsh, you all could also take up some questions yourself because it's such a primary important topic.
Yeah, so I just want to reiterate what Krishnadas said, very, very important. If you let the things go for a longer time, whether you release or whether you cut the suture, nothing is going to happen.
Yeah.
So you do a massage. Massage is a very, very important part and it has to be taught to the patient. So many of our patients are from outside. So you'd have to teach them how exactly to do the massage, make them sit down. Once you have taught them how to do a massage, make them sit down in the OPD till the pressure builds up again. See after how much time the pressure is building up. Maybe it is an hour or 2 hours, and then so that you can tell them that, okay, the massage is to be done every 2 hourly. The next time, let him do it by their own hand. And then you know how much of the pressure is coming down. So if the massage is doing the thing well, otherwise you remove the suture, but remove it in early May, not later than 3 weeks. Definitely after that, sometimes removing doesn't help at all.
Yes. Dr. Murli, any other question?
I had a question about Ologen. I mean, how many of us are still using Ologen? I mean, does it continue to have a role?
At least I asked a couple of my friends in the institute, and I think pretty much everybody has given up using it. So it still theoretically remains on the block, but frankly speaking, it has a learning curve also. So unless there are a couple of people who regularly use it, but then I guess you have to be really good at it.
Okay.
Another problem with Ologen, sir, is that it's very, I find it very scary to modulate the wound after that. You have a sponge sitting there and you don't want to inject a 5FU or needle or something. So that's the other problem. So yeah, same here. We've also sort of given up. We don't use it.
If we were to do a trabeculectomy in a neovascular glaucoma, any extra tips which you all would like to give?
Always anti-VEGF prior to surgery, about a week. So even if we can't see it, maybe there are some hidden vessels somewhere. So that is one. If we could do a complete PRP, which is possible, that's the best thing. If we could wait. But otherwise, pretty much MMC and everything else, nothing.
One interesting thing is that, which I learned, we always learn while we are in trouble. So if you have done all that, what Sushmita has said rightly, and yet when you open up and you are doing a PI, you suddenly realize there is a vessel staring at you. So I pick it up with the forceps of the coagulator, and then you coagulate it and then cut it, and then you get away with it. And if suppose it still bleeds, then do fill up with Visco. Visco immediately stops the bleeding, and then after some time you can actually wash it off.
Would anybody think of placing mitomycin sponge under the scleral flap in some of these cases in neovascular glaucoma? Would you also believe in doing a cyclodialysis augmented trab in these cases to get a better IOP control?
Subhashini and Ratini, what are your practices in your institutions? Neovascular glaucoma, Travicolotomy. An additional factor would be use of anti-VEGF prior to Travicolotomy. Sometimes we combine it with Travicolotomy when one dose of anti-VEGF is insufficient to regress the vessels and neovascularization. Sometimes combining it with the anti-VEGF intraoperatively also assists in reducing the neovascularization.
Dr.
Yes,
Rasmi, yes, Vashini, yes.
As Shushmita madam said, we usually use it 1 or 2 weeks prior. Anti-VEGFs we use 1 or 2 weeks prior to doing the trabeculectomy surgery. But now I moved away from traps and started doing tubes right away in such sort of cases, because the success rate is tremendously low.
And Dr.
Ratini and Devendra. Ratini and Devendra.
We also yes, ma'am. We also usually try to give an injection anti-VEGF prior to the surgery, at least 3-4 days. But in some cases, when the surgery has to be done immediately and the NVI is regressed to a certain extent, then we combine it along with the trabeculectomy. As far as possible, trabeculectomy is primarily preferred. But if the Seneca is too anterior, then possibly, and the NVI is still present, then we maybe opt for a tube, sir.
Dr. Devendra?
Yeah, we also used to be, initially if neovascularization is completely, PRP has done, eyes were settled and quiet, we can try the trap. But if we find out is a little bit unstable, we used to do the tubes. If you're confident, I prefer tube is a much better outcome in compared to the trap with MMC.
Okay. Thank you very much. I think we
we have to, because most of the people who are listening to us have never done tubes, a whole lot of them.
Yes.
So I think it's fair enough to say that yes, you first give an anti-VEGF, 3 days later you do a trap. If the trap doesn't work, or you feel that there is too many synechiae and the chamber is shallow and the vessels are not dying down, despite everything, yes, then please refer for a tube. But otherwise, by and large, you can, the first trap is a reasonable option.
Would you be aggressive about placing mitomycin under the scleral flap too?
Then that I haven't actually done it, so I'm not really.
Oh, okay. Okay. We shall, I think we need to really cover a lot. We are going to be stuck together till 9:30 today because I've been going too slow. We shall go on to our next speaker, Dr. Ratni David, who again is a senior consultant glaucoma services at Shankar Nethralaya. And she's going to be talking on another very important topic, managing tube exposure smile pearls. On to you, Dr. Ratni. No, I'm sorry. Her topic is needle revision and surgical revision of failing blebs. So very sorry. What can we hope to achieve?
Thank you, ma'am. I'd like to thank ARC for the opportunity. Needle revision and surgical revision of failing blebs, what we hope to achieve. Trabeculectomy is still the most preferred anti-glaucoma surgery. Numerous modifications have been tried over the ages to achieve the ideal bleb. A functioning bleb must be low, diffuse, moderately thin-walled, relatively avascular with presence of microcysts. Post-operative management of the filtering bleb is just as vital as performing the trabeculectomy itself. Failure of filtering surgery occurs at various levels, namely at the level of the internal ostium or at the scleral flap level and at the subconjunctival level. It is important to look out for early signs of bleb failure, namely such as elevation of intraocular pressure, signs of vascularization, hyperemia, and flat bleb with the disappearance of the microcyst. Steroids go a long way in wound modulation, and they help to act in the early phase of the inflammatory cascade. An intense topical steroid regimen is usually advocated to reduce inflammation and hence scarring. Injecting antifibrotics like 5-FU usually at the appearance of vascularization and also helps to inhibit fibroblastic proliferation. This is, shorter video of injecting 5-FU.
A cotton bud soaked in tropical proparcaine is kept on the intended site of injection well away from the bleb for a minute, and then the injection 5-fluorouracil in a dose of 5 milligrams in 0.1 ml is injected by creating a long needle tract in order to avoid spillover of the drug from the tract. The cotton bud is again placed at the site of injection to alleviate pain, and it also helps in diffusing the drug.
In case of a flat bleb with raised intraocular pressure in the early postoperative period, the decision to manipulate the scleral flap sutures is usually based on the bleb morphology as well as the intraocular pressure. Suture removal usually works best when done within 3 weeks postoperatively. The techniques of scleral flap manipulation include bleb massage to facilitate the aqueous outflow through the scleral flap edges, removal of releasable sutures, argon laser suture lysis, and bleb needling. Bleb needling is considered a less invasive and a useful alternative in the setting of a failing trabeculectomy, especially when suture lysis or releasable suture removal does not have much of an effect. The aim of needling is to release the scarring and fibrosis at the subconjunctival and the episcleral interface using a needle and increasing the subtenon's aqueous lakes, thereby restoring the bleb function. It's noteworthy to avoid use of anti-glaucoma agents in the early post-op as it further reduces filtration of aqueous and thereby increases contact between the conjunctiva and episclera, promoting fibrosis and potentiating scarring. Some of the prerequisites before needling include a careful slit lamp examination of the bleb, look for encystment or whether it is a flat bleb with the conjunctiva adherent to the sclera or a small thin cystic bleb. Conioscopy is mandatory to confirm the patency of the ostium and to rule out the presence of any iris or vitreous plugging the ostium. The procedure has maximum benefit when performed within the first 3 months of surgery. The success is reported to be much better in elevated encysted blebs rather than flat blebs, especially when performed in the first 3 months. Needling can be performed as an office procedure in the slit lamp under sterile precautions or in the operating theater, where it can be done in a more controlled fashion. Sometimes more than one revision may be required. The use of adjuvants like antimetabolites have increased the success of the procedure. Mitomycin C is definitely more superior than 5-fluorouracil when it comes to needling, and MMC needle blebs need fewer revisions. The methods of application described are numerous. Some of them include subconjunctival MMC injection, transconjunctival MMC soaked sponges placed over the intact sclera, and injecting 5-FU subconjunctively at the end of needling. The choice of the cutting device varies from surgeon to surgeon. A 30-gauge needle may be too thin and flexible to break the adhesions. A 26 or 27-gauge needle may be ideal. A 23-gauge MBR blade may also be used in thick-walled blebs. The short video on needling.
Bleb needling is done with the aim of breaking the fibrotic adhesions at the subconjunctival and episcleral level, and thereby re-establishing the outflow from the anterior chamber to the subconjunctival space. Use of antifibrotics during needling improves the success of the procedure. In this video, 0.1 ml of mitomycin C in the dose of 0.4 milligram per ml is injected posterior to the bleb, and the drug is dispersed into the bleb with the help of a cotton bud 20 minutes prior to the procedure. Then a 27-gauge needle is bent and introduced into the subconjunctival space about 5 millimeters away from the bleb. Multiple punctures and sweeping movements are made with the needle in order to break the fibrotic adhesions. one can observe the bleb forming, and then a paracentesis is created, and on hydration, a diffuse bleb is formed.
Sometimes it may be required to revise the internal ostium also by passing the a spatula through the anterior chamber into the ostium. It can needling can also be performed at the slit lamp, where a 27 gauge needle is bent and it's passed subconjunctivally advanced towards the scleral flap, and by gently sweeping motions, the episcleral adhesions are broken, and one can see the bleb reforming. Sometimes thereafter, it has to be augmented by injection 5 FUs and teaching the patient to do a bleb massage. This is how encapsulated it looked before needling, and after needling, you can see a low diffuse bleb. Needling with 5-fluorouracil is an effective intervention in the short and medium term, but long-term results show that it needs additional intervention. Needling with MMC is effective for controlling IOP even several years after the original trabeculectomy. The success criteria in various studies have different definitions, and repeat needlings have also been.
You have 1 minute remaining.
No, repeat needling has also been included within the success definitions, and the concentrations of antimetabolites also vary from study to study, making comparisons difficult. A systematic review and meta-analysis done by Shen et al. They reported that the MMC group had a success of 48% and complete success, and a qualified success of 70%. And the 5FU group, they had a complete success of 44% and a qualified success of 70%. The risk factors for failure include duration more than 3 months, younger age, phakics, prior multiple surgeries, previous multiple attempts at needling, high pre-needling IOP, and high post-needling IOP of more than 10 millimeters of mercury. The complications usually reported are intra-bleb hemorrhage, which is the commonest, bleb leaks, overfiltering, shallow anterior chamber, choroidals, and blebitis. Usually, bleb leaks and overfiltering are usually self-limiting. In some cases, conservative management like BCL application, aqueous suppressant, and reducing steroids may be needed. In case of persistent hypotony, one may need to resort to surgical interventions like AC reformation, resuturing, and choroidal drainage. So the conclusion is bleb needling is a safe and effective method and can be tried in failing filtering surgery. It is prudent to try needling before resorting to any medical or further aggressive surgical interventions. Thank you for the opportunity.
That was a wonderful talk. I'm just going to take 2 rapid questions with you. How early or how late would you do a needling? And what is the endpoint of injecting 5FU? Like how many 5FUs would you give? Dr. Agni?
Yes, usually we needle even early in the early post-operative period, even as early as 2-3 weeks if we see any encystment and or an elevated IOP. Needling can be done even up to 2 years, but however the success definitely decreases with time. And 5FUs usually up to 5 to 6, not more than that. It usually doesn't really have much of an effect beyond that number.
Murli, you have any question to ask before we go on to our next speaker?
Yeah, I have one question which I forgot to ask the panel. What is your policy in treating aphakic glaucoma? I mean, sometimes you get patients who have had a complicated cataract surgery outside, have an iris clip IOL in place, or some such, or a large PCR. So, and if they needed a trab sometime in a trab or some kind of a glaucoma surgical procedure in future, what would be the choice of the panel?
Only I really want to say something that a very excellent talk about the needling, very, very nice videos, but please remember that even years and years later, you can do it successfully. Yes. So there's really no time gap. As a matter of fact, I had a patient who had done 10 years back and they wanted to go out. So Robert Rich did it for them and then put 5FU over there. 10 years later, it is now functioning beautifully for 5 more years. So there's really no time limit for that, for doing a needling.
The internal ostium is clogged by iris or so. I mean, is it worthwhile trying to sweep the iris out and do a needling? Usually the bleb would be flat in these cases.
Yes, yes, it makes sense. We have to release the ostium and then only go on to combine it with needling, because by the time there's subconjunctival and subscleral fibrosis also. Yes. And your other question, Murli, you had asked?
Yeah, was about managing glaucoma.
Aphakic glaucoma. Anyone, Dr. Krishnadas, Dr. Shushmita, you have anything to add on that?
My choice for aphakic glaucomas would be a tube, one of the few for primary tube. I usually wouldn't do a trab in that, they somehow fail. And just one small thing about needling, I always do a gonioscopy before.
Yes.
And it tells me whether or not the subtenons might, because if the fish mouthing is there of the internal ostium, it tells me that it's probably subtenons. But if it's like a slit, that's probably that it's closed, and just a subtenons may not work in that, just a small tip.
Yes, a very relevant.
This aphakic glaucoma, does it include the iris claw IOLs and other complicated cataract surgeries like SF IOLs which are done by, I mean, would that also fall under the ambit of aphakic glaucoma? If they develop a glaucoma, you would still consider a tube?
Yeah. Once cataract surgery is done, I would usually, somehow the trabs don't seem to work so well. Once cataract surgery has glaucoma with them. So I do a tube, but that's my personal preference.
Dr. Krishnadas?
I agree with Sushmita. For aphakic eyes, trabs do not work, and complications are also higher, like choroidal effusions, hemorrhage. Such drastic complications are also higher with trabeculectomies in aphakia. The only exemption probably would be a nicely placed PCIOL, uneven full PCIOL implantation without complications, with untouched conjunctival, clear corneal phaco done earlier. These eyes trabs work very well. In fact, they work better than aphakic eyes I have seen. But aphakic eyes, whether it iris claw or SF IOL, it's preferable to probably do.
Yes. Thank you very much, doctors. We shall now go on to our next speaker, Dr. Talveer Sidhu, who is assistant professor in Government Medical College, Patiala, young, dynamic, smart surgeon. And she is going to tell us about managing late complications of trabeculectomy. The battle is neither over nor lost. On to you.
Am I audible, ma'am? Is my screen visible?
Yes.
I would like to thank ARC for the opportunity, and also I would like to thank my mentors, Professor Sihota and Professor Dada, at the start of this presentation. I have no financial disclosures. When we look at the publications, major publications on long-term complications of trabeculectomy, the CIGTS, which looked at trabeculectomies at 5 years and more, they said that the cataract extraction is one of the most common complications, followed by Bleb-related complications like Bleb leaks and Bleb revisions, which were needed, which were majority of the complications, and almost 1% had hypotony or endophthalmitis at the end. Now, looking at an ideal Bleb, as Dr. Ratni has already said, it's a very diffuse, mildly vascular, well-functioning Bleb, which is not over-functional or less functional, and the IOP is well-maintained. But long-term Bleb outcomes, they vary from an ideal Bleb. They might become thin cystic Blebs, just like this one, or overhanging Blebs. And on the other side of the scenario, we have the encysted and flat failing Blebs, which might be present. The thin cystic Blebs, which might be present, might have just the conjunctiva overlying the Bleb, which has become thin because of use of antimetabolites, or there might be associated scleral thinning, which might be present in the along with the thin Blebs. And sometimes the conjunctiva might override the cornea or have very large overfiltering Blebs where intraocular pressure might be low along with that. So this is a video which shows that Bleb sweating is a phenomenon that might happen as the Blebs, they start thinning out. When you put fluorescein dye over the Bleb, you can see patches of fluorescein dye becoming diluted. And moreover, in similar Blebs, if you put pressure over the globe, you would see that along with the sweating, there are patches of conjunctiva which are thin and they start leaking when you apply pressure over the globe, which is a pressure Siedel's positive test. Sometimes we also see minor leaks in the Blebs, which might be present late. So this was a patient who had undergone a Bleb revision. And after that, along the suture tract, there was a minor Bleb leak that was present. And sometimes profuse leaks. This patient had a trauma. And following the trauma, he had a very profuse leak from the Bleb area. So these can be associated with a persistent hypotony, which can lead to visual loss due to hypotony maculopathy if it is present for more than 6 to 8 weeks. And persistent hypotony without any thinning of the bleb might also be present in young age and juvenile open angle glaucomas, myopias, people presenting with very high intraocular pressures, persistent iridocyclitis, or very high use of antimetabolites. So that can actually be managed with the help of pressure patching or a large PCL. This is a picture which shows injection of autologous blood into the bleb from a paper from Dr. Vijay ma'am. And they have actually given good results after use of autologous blood in the blebs which are overfiltrate. But blebs which have sweating or minute leaks, we have tried oral doxycycline. So this was the patient we had seen earlier who had undergone bleb revision because he had prolonged hypotony. And this bleb leak which was present, actually we did not again try to put any other sutures. We just gave him oral doxycycline. And you can see that the hole that was present near the conjunctiva has actually healed. The steroids were minimized, and after 2 weeks of oral doxycycline, we can see that the minute leak that was present has disappeared. Also, bleb revision surgeries may be done for leaking overhanging blebs. In earlier times, we used to use a bare sclera technique where the bleb was removed and the conjunctiva was actually advanced onto the bleb area. If the conjunctiva was not advanced, a flap of conjunctiva may be used from the other side. But the problem with bare sclera technique is that sometimes the post-operative period, the pressures might become high due to fibrosis of the entire bleb. Therefore, Professor Sihota has described this technique of bleb-sparing epithelial exchange. We have separated the conjunctiva around the bleb area, and we have stained with trypan blue the epithelium which is present over the thin epithelium which is present over the bleb area. So we are only removing the thin epithelium which is present over the bleb area so that the underlying bleb structure which is formed by the tenons is not disturbed. And after this, we can actually advance the conjunctiva over the bleb structure. If we only advance the conjunctiva over the bleb structure, this epithelium makes sure that there is no adhesion of the conjunctiva and it tends to get receded post-operatively. Therefore, this is a very important step while we are doing this surgery. Sometimes when there are scleral thinning also present with profuse leak from the bleb, this was a patient who had a very small area of scleral thinning. Here we actually separated the conjunctiva over the bleb area, and after separating the conjunctiva over the bleb area, we used ologen as a scaffold. We did not use a scleral patch graft over this thin area. We just put the ologen graft over this thin area and sutured it and advanced the conjunctiva over the ologen. And you can see this is a post-operative picture around a month or 6 weeks post-operative picture of the patient, which shows a very well adhered conjunctiva. And this also makes sure that there is some filtering that is happening into the bleb. If we put a scleral patch graft over such small areas, they close immediately and the intraocular pressures post-operatively might rise. So ologen is a very good option in these cases. Similarly, a thin bleb with a full thickness scleral defect usually needs a scleral patch graft. Here we used a scleral patch graft. We used a Refine to cut out a very small scleral patch which was tucked into the full thickness scleral defect that was present. After tucking in the scleral graft, there was also a thinning of the cornea that is actually seen over along the bleb. So therefore, here also we used an ologen graft and advanced the conjunctiva onto the bleb. And this is a post-operative 3-month picture where the patient is seen to have a cataract and a very well adhered conjunctiva, and there is no scleral thinning that was residual. Another important technique is when you do not have any sclera present with you, or you do not have ologen, the patient is not affording an ologen, you can actually rotate the patient's own sclera onto the scleral graft. So here onto the scleral thinning area, which is a Momini's patch repair of scleral patch necrosis. The important thing to note is that Bleb-related infections can happen in up to 3% of people who are having very thin blebs and have leaks and they go unnoticed. Most important thing we all know is how to treat a blebitis, and usually it's a very difficult thing to treat, but the prevention of blebitis is important and is fairly easy if you make the patient aware of the fact that there is a bleb present in the eye. It's important to avoid trauma. Use of polycarbonate glasses in such patients must be advocated. Also, you need to tell the patient that once in a while they can just lift up the upper lid and see whether there is a redness swelling around the area which is where the bleb is present. Also, we used to direct these patients to keep a eye drop of moxifloxacin at home all the time. In case if there is any redness, the patient can start putting the eye drops, and the very same day, or if the patient comes from afar, very next day he can present to the hospital. So this counseling is very important for the patients. And another scenario which already has been discussed by Dr. Ratni ma'am is how to assess and manage a failing bleb, which are of usually two types: hypervascular flat failing bleb or encysted blebs. And in hypervascular flat failing blebs, not just 5-fluorouracil, we have also used mitomycin C 0.04%, on only topical mitomycin with the help of a Mirocell sponge, which is kept for 3 minutes over the bleb area and washed off. And there is definite reduction in the conjunctival vessels. Also, along with that, as Dr. Harsh sir has said, that ocular massage is a very important thing. So with a hypervascular flat failing bleb, ocular digital massage has to be taught to the patient. And always do a gonioscope to look for any internal blockage so that can be removed. Encysted blebs usually require, usually have a tenon cyst formation and they require needling. And late bleb failure, which can happen due to subconjunctival fibrosis. A paper by Professor Sihota on 10-year follow-up of trabeculectomies that she has done, it shows that in long term, 50% of the patients, they do not need any medications after trabeculectomy, but around 45% of patients might need 1 to 3 medications. Majority of them, you would usually need only 1 medication to achieve the target IOP. So it's important to understand that after you have done a trabeculectomy, the target IOP has to be looked at. If the target IOP is not achieved and it is a hypofunctioning bleb, then we have to give 1 or 2 medications to achieve the target intraocular pressure, and side by side other procedures might be done. So thank you very much. This is all about my talk about the failing blebs, also about the hyperfunctional and the thin cystic blebs. Thank you.
Extremely wonderful talk, and so many beautiful videos have been shown which are so self-explanatory. So paucity of time, we are going to go on to the next speaker, though you really justify a whole lot of panel discussion. We go on to our next speaker, Dr. Subhashini Kaliyaparimal, who's the head of the Department of Glaucoma and Cataract and Refractive Services at JIPMER, Pondicherry, and she's going to talk on glaucoma drainage devices, a note for trainees and beginners.
Thank you, Madam. As Madam said, I would be talking on GDDs, a note for trainees and beginners. Gone are the days when glaucoma drainage devices were used as a last resort for refractory glaucomas. Nowadays, GDDs are used on par with trabeculectomies. This is mainly because of 2 reasons. There is enough evidence to show, especially there is this tube versus trab study, which has shown that tubes have comparable outcomes to trabs. And in fact, the cumulative probability of failure in the TVT study was only just 30% in the tube group and almost 50% in the trab group. And even the primary tube versus trab study has shown that the results of tubes are comparable to trabs. In India, the two commonly used devices are the Armeth glaucoma valve and the Orolab aqueous drainage implant, or the RD. This has revolutionized glaucoma surgery since it became available in 2013. This is modeled on Burwell implant. As I said, the second reason GDDs have become popular is because of this availability of this low-cost device. It costs just 3,500 as compared to the actual Burwell implant, which costs almost 50 to 60,000, and it's only 1/5 of the cost of AGV. For the beginner or the trainee, it makes sense to use AGV in the initial few cases because the size of it is small. The area is around 184 millimeter squares compared to the RD implant, which is 350 millimeter square. And the other reason, of course, because it's a valved implant, there's no need for tube ligation or a ripcord suture. So I have divided the surgery into 8 important steps. The first is the conjunctival dissection, the conjunctival peritomy. I usually prefer at least 5 clock hours of conjunctival dissection. The recommended area where the first implant is placed is the supratemporal quadrant. So you need a good adequate dissection. You can even make some side cuts to have a good exposure, and then open up the area where you want the implant to sit. The second step is the muscle traction. At least for the beginner, it's better to take traction sutures of the superior rectus and the lateral rectus. And this is done using a 3/0 silk suture. You can see how the needle is passed reverse so as not to injure the sclera. The assistant can then pull these sutures, infranasally, these traction sutures, and you have a good exposure. The next step is priming. So once the GDD is out of the pack, then you have to prime where you inject fluid through a 30-gauge cannula and see for the flow to make sure there's no manufacturing defect. Then you can do the tube ligation. This step, some people do it after inserting the plate. So then again, you check the patency. So there should be, just make sure that there is no flow. The next step would be insertion of the plate. Here I'm using a RD implant. You insert, because it's a large one, the wings of these implant of the plate should go well behind the belly of the superior and the lateral rectus muscle. So just ensure that it's under the muscle so as to prevent migration of the implant as well as to prevent extraocular movement restriction. Then once you position the plate, then the next step would be to anchor the plate now. The anterior end of the plate should be around 8 to 10 millimeter from the limbus. So then with a 8/0 nylon, you can take a bite through the sclera, just like for scleral buckling. You should see the needle pass through the sclera. Then you pass it through the fenestration and suture it, and you need to bury the suture. That's important. Similarly, the other side also, you can take a bite through the same 8/0 nylon. And then one last time, you just ensure that the wings of the plate are under the muscle. The next step is the tube insertion. So here you first mark 2.5 millimeter from the limbus, and that is the point where you are going to make the track and cauterize the area. And then you can cut adequate length of the tube. So at least 2 to 3 millimeter from the limbus, you can cut using the Westcott scissors, beveled up. So this will help in ease of inserting the tube to the track, through the track. Then a paracentesis temporally. So this is to inject the viscoelastic. HPMC can be used. And here you basically want the iris to nicely go down, push it back. And then with the 23 gauge bent needle, you can make a track and slowly just wriggle it into the chamber, ensuring that it's not so close, too close to the cornea or to the iris. So once you've made the track, you can inject some viscoelastic into the track and then insert the tube just with a McPherson. And once you have inserted—
You have 1 minute remaining, ma'am.
I'll just take 2 more minutes. The viscoelastic is then burped out, and then you have to anchor the tube so that it doesn't retract. This is done with a 10-0 nylon or 8-0 nylon. And then placing the scleral patch to cover it. Some people use the scleral, make a scleral tunnel itself. So for the beginner, it would be good to use a scleral patch graft to cover the tube to prevent tube eroding through the conjunctiva. Then the next step, the final step, is the conjunctival suturing. So here again, you need to be as careful as for a trap. Handling is important. Any buttonholes you will have to suture, and you have to ensure that there is no leak, because here also there is a bleb which forms over the plate. So the instruments and suture materials are nothing special. So just ensure that you have a 23 gauge needle and muscle hooks. Suture materials are, as you have seen in the video, it's 3/0 silk for the traction sutures, 8/0 nylon for anchoring the plate, 6/0 or 7/0 for the ligature, patch graft, and conjunctival suturing, or you can even use fibrin glue, and 10/0 nylon for anchoring the tube. In case you ripcord suture you're using, it can be used in a very advanced glaucoma with high pre-op IOP. So here you can see a 5/0 Prolene I'm using. It has to go from the plate side, and then you pass it under the conjunctiva, and it comes out inferiorly. You can cut the remaining suture, and a small bit remains there. In the post-op period, you can just pull it in case the pressures are very high. Post-op management is with topical antibiotics and steroids for 6 weeks, and anti-glaucoma medications you will have to continue for 3 to 6 weeks if a non-valved GDD is used. So complications, hypertony-related complications, tube exposure, extraocular muscle restrictions do occur, but these are part and parcel of any surgery. To conclude, GDD can be the first line of management in certain cases. So it is better to be familiar with the use of GDD. If you can do a good trab, you can also do a good glaucoma drainage device implantation too. Thank you.
Excellent, truly excellent teaching video, Dr. Subhashini, but I'm sorry, I'll have to hold back on the questions. A very good talk.
Thank you.
We shall go on to our next speaker, Dr. Swati Upadhyay, who is a medical consultant glaucoma services from Arvind Rai Hospital, Pondicherry. And she's going to tell us about CAT and the tips on case selection and surgical technique. And I think it's getting more and more popular. So we look forward to hearing from you.
Thank you, ma'am. Thank you so much for this opportunity. I hope my slides are visible.
Yes.
Yeah. So I'll be talking on tips on case selection and surgical technique for achieving best results. So as we all know, gonioscopy-assisted transluminal trabeculotomy is the brainchild of Dr. Davinder Grover and Dr. Ronald Feldman, and they came up with this technique in 2014, which involves cannulating 360 degrees of the Schlemm's canal by passing a Prolene suture or an eye-track microcatheter, creating a 360 degrees trabeculotomy. Prerequisites for any mix are sound knowledge of the angle anatomy, suitable surgical gonial lenses, both direct and indirect, mastery over direct and indirect intra-op gonioscopy, which means patient and microscope positioning, tiltable microscope, mastery of microscope foot pedal, and ambidexterity and patience. The preoperative test for suture guide will be, first is a patient selection. So who are the patients who are really, you should take up when you are starting GAT? These are the mild and moderate glaucomas, POAGs, pseudoexfoliative glaucoma, pigmentary glaucoma, and ocular hypertension. So which gonioscopy would I, if a patient is having an angle like this, where all the structures are clearly visible, the scleral spur is the most important landmark. If you can see the scleral spur in the nasal angle, these patients are the first to try on. In contrast to these type of angles which are like not having a clear-cut demarcation of the scleral spur, the iris pigments are dispersed throughout. So these should not be the first ones to be selected. So please select clear-cut cases where scleral spur is clearly visible. So before you start, you should do intraop gonioscopy. You should practice intraop gonioscopy in your routine phaco cases. So for that, you need positioning. So turn the patient's head 35 degrees away from you and tilt the microscope 35 degrees towards you. Use a high viscosity cohesive viscoelastic. Either you can have Helon GV, and if Helon GV is not available, then you can have Orogel, which is also 14 milligram per ml viscosity. Now the patient positioning at the table positioning is very important. You should have the table in a slanting reverse Trendelenburg's works position, so that the head of head of the patient is above the heart level. So tilt the OT table so that the head end gets elevated. How this will help? It will prevent blood reflex from the Schlemm's canal. So this is the way we should keep our OT table. And also preoperative counseling is very, very important, because most of the patients, or maybe I would say more than 50% of the patients, might have hyphema. So this is a video showing intraop gonioscopy with a Swan-Jacob gonioprism. So you put OVD or a cohesive viscoelastic on top of the cornea. After proper patient and microscope positioning, you put the lens in your non-dominant hand, so that in the dominant hand you can have the MST forceps. So this beautifully you can see the angle structure, the scleral spur. And this will improve, go on refining as you practice intraop gonioscopy. So the intraoperative problems or complications which can face is either they can be bleeding from the Schlemm's canal. The moment you give a nick or the limited goniotomy, you can have bleeding from the Schlemm's canal. You can have a non-advancing suture. You can have a false passage and your suture keeps on going and it doesn't appear from the other side. So you must suspect false passage. Shallowing of anterior chamber can also happen. So my tips would be to reduce bleeding from the Schlemm's canal. You should have head above the heart, as I showed. Lift the head end of the operating table. This will reduce reflux from the Schlemm's canal and the collector channels. Use high viscosity OVD. Now to avoid false passage, what we should do, we should first use intracameral pilocarpine so that the iris constricts and the angle structures are clearly visible. We should have proper understanding of the angle structures. We should not confuse trabecular meshwork with ciliary body band. Blunt the tip of the 50 proline suture into a little mushroom, as you can see on the left hand side, as compared to the right hand side suture, which you can see it's a very large bulb. So if you have a very large mushroom at the tip, it can easily create a false passage. So it should be just the blunting of the tip. The limited initial goniotomy should be just 1 clock hour, so that you don't open the all the visible nasal angle. So then what will happen is, when you do a limited goniotomy, you will see the suture being fed into the Schlemm's canal and you can see it through the trabecular meshwork. And confirm the suture in the Schlemm's canal while doing initially when you feel that you have done 90 degrees of GAD, or you have proceeded 90 degrees, take an indirect gonio lens, put it onto the cornea and see, confirm. So the arrow showing there is that the suture, the blue color is seen through the trabecular meshwork, and you can find that yes, my suture is in the Schlemm's canal. I can see the scleral spur below my suture. So in the second picture, you can see that half of the suture has reached halfway and the halfway it has not reached. So you can still confirm that yes, I am in the Schlemm's canal. What about a non-advancing suture? So always pre-measure the suture, just make a loop around the cornea and just have a rough estimate. Okay, this much suture I'll be needing, and kink the 50 proline at a place where, okay, you just have an estimate that yes, this is a suture. If the kink appears, then definitely, and my suture hasn't appeared from the other side, then definitely I'm in a wrong place. Confirm the suture present in the Schlemm's canal, as I already told. If from one side the suture is not proceeding, then you can switch to a twin side or just try feeding the suture from the opposite side. So if you are doing a left eye and you have started from the superior side, if the suture is not proceeding, then you can make an inferior paracentesis and then start feeding the suture from the opposite side. Resistance will be felt at 180 degrees, which is a good sign. What about having a shallowing of anterior chamber while doing intraop gonioscopy and GAD? So use high viscosity OVD, Hemangioma or Orogel, as I told, so that the anterior chamber is well formed throughout the surgery, and do a gentle placement of the gonio lens. And you should not have folds in the cornea. If you're pressing too much with your non-dominant hand onto the cornea, you will have Descemet's folds, the corneal folds. Now, what about the post-operative complications? Hyphema. You can have a varied variety of hyphema. If you're lucky enough, the patient will not have hyphema on POD1. But you can have diffuse microhyphema, or you can have a layered hyphema. So we don't have to panic if we have counseled the patient well off before surgery that yes, some amount of bleeding will be there because we are opening the 360-degree channel, and you should not panic. Within 1 week, the blood will resolve. And always we have to ask the patient to sleep on the side of surgery so that whatever hyphema occurs, it will accumulate on the temporal side, and the nasal angle, which has the maximum collector channels, will still be open. So we have to remember to tell the patient to sleep on the side of surgery, which is very, very important. So if you have hyphema, preoperative counseling, discussing possible risk factors with the patient and one caregiver is very important. In the end, when you have completed GAD, just fill the anterior chamber with Hemangioma or Orogel. Leave 30%, like 30% filling of the anterior chamber can be done with Orogel. And believe me, this will not cause high intraocular pressure post-operatively. And even if the pressures are little on the higher side, we can use alpha agonist BD dosage for 7 days. And also we can use pilocarpine BD for 7 days. Most of the hyphemas are self-resolving and they disappear in 7 days. What if you have a choroidal detachment due to a false passage? Then this is the first day post-operative period, which in a patient which I had a false passage, and I could realize on the table itself that my suture is going in some other direction. So I retrieved my suture back, again reassess the angle anatomy, again reassess my maneuver where I'm putting my suture. Then I fed it from the opposite side, and then I had a 360 degrees successful GAD. So the patient was put on systemic steroids in tapering doses, and also topical steroids were continued. And this is the post-operative day 15 that CDs had resolved completely and the patient had 6/9 vision. These are some of the pictures what you see in a post-operative period in a gonioscopy.
And 1 minute remaining.
So you see a cleft like this. These are the white, this is the white wall. The sclera is seen because you have removed the trabecular meshwork covering the Schlemm canal. So this is a cleft which we normally look for, but we can have surprises in the form of small pars, peripheral anterior synechia, but these pars are not extensive. So we don't convert an open angle into a closed angle as many people think that we are converting an open angle into a closed angle, which is not the basic actual reality. Sometimes we can have still blood oozing from the Schlemm canal, as you can see from on the left hand side, on the right hand side picture. A small blood clots or small oozing from the Schlemm canal will be there, and if you make the patient hypotonous, then you can see the blood reflex directly. So my take home messages will be the 10 commandments. Select moderate open angle glaucoma cases to begin with. Use widely open angles on gonioscopy. Do a very good preoperative counseling. Practice intraop gonioscopy on your routine phaco cases. Don't make large initial goniotomy. Just 1 clock hour is enough. Feed the suture in the Schlemm canal. Don't push it. So when you put this, feed it into the Schlemm canal, it will very nicely take its path and come from the opposite side. Keep the head above the heart to the table tilt. Use liberal high molecular weight OVD. Use indirect gonio lens to confirm suture position, and be patient and perseverant. I would like to thank my mentors, Dr. Venkatesh and Dr. Davinder Grover. One to make me take this path of MIGS, and one to teach me GAT and other MIGS. Thank you so much.
Yes, Dr. Swati, that was an amazing talk. I had an opportunity to hear you in GSI, and I knew you would be excellent. We are not going to take questions. We need to do justice to the next 3 speakers. So just stay on. We'll do some panel discussion afterwards. Our next speaker is Dr. Devendra Maheshwari, who's again a senior medical consultant, glaucoma services at Arvind Eye Hospital, Tirunelveli. And he's going to talk on something very important: micropulse transscleral photocoagulation and cyclodestructive procedures. On to you, Dr. Devendra.
Yeah, good evening, everyone. And thank you, Chitra Madam and ARC team for giving this opportunity. So today I'm going to talk about the micropulse transscleral cytophotocoagulation and cyclodestructive procedure. As all we know that traditionally glaucoma management starts with the medical treatment. If fails, we consider surgical option, and cyclodestructive procedure considered at the last last choice. With the newer development, newer modalities like the micropulse and ECP, increasing used in the moderate to advanced glaucoma with good eye visions. So in the cyclorestriction has a long history. It started long back in 1930. The cyclotherapy and diathermy has been used long back in the past, but it has been discontinued because of various complications and the adverse effect. So currently used cyclorestrictive procedure are diode CPC, micropulse, endoscopic CPC. Coming to the high intensity ultrasound cytophotocoagulation, this is the method in which the circular probe has been used to produce a thermal necrosis by using an ultrasound energy. It's a novel method, but it does not depend on the pigmentation of the ciliary body. However, there's a few clinical studies has shown good outcome, but still there's a long-term prospective and randomized control study are needed to come into the clinical practice. Coming to the endocytophotocoagulation, it is a selective ablation of aqueous producing ciliary process via the ab interno approach. In this procedure, this ECP probe contains the diode endolaser, aiming beam, light source, and endoscope, which allows us to control ablation of the ciliary process. It can be done either by the limbal or the past lane approach. This procedure is suitable for the patient who has a thin sclera, ectasia, especially pseudophilic and aphakic cases. However, the fewer studies have shown the CPC has a good outcome and combined with phacoemulsification, but still this no randomized prospective studies are comparing the ECP with conventional cytophotocoagulation and ECP. Apart from that, the CPC always, endoscopic CPC always associated with the high post-operative complication like severe inflammation, cystoid macular edema, and the vision loss. So most commonly used transscleral diode cytophotocoagulation are continuous wave CPC and micropulse. So what are the indications for this procedure, especially neovascular traumatic and aphakic glaucoma not responding to conventional treatment, and the glaucoma following the penetrating keratoplasty and post-VR surgery like silicon emulsified glaucoma, post-buccal glaucoma, and the eyes who had underwent the multiple trabeculectomies and they have the history of the GDD, still IOP is high. Apart from that, in the recent time, there's a development of the new laser like the micropulse. These micropulse can be used in the moderate glaucoma with useful good vision. How it works? The diode laser is applied to the ciliary body and that destroy the ciliary epithelium and reduce the vascular perfusion, thus reducing the ocular production and reduce the IOP. So coming to the continuous wave diode cytophotocoagulation, this is the machine console, and this diode laser is delivered through the fiber optic handpiece. This is called the G probe, and this is the foot plate. This procedure can be done either in the block room or in the operating room. We used to do in the operating room, and the setting has to be recommended, has to keep low and slow. So keep the power around 1200 to 1500 milliwatt and duration around that 3000 millisecond. So this is a surgical video. So after having the perivalvular retrobulbar block, this G probe has to keep at the limbus. When giving the second spot, we have to keep in mind the probe edge has to keep the halfway of the first spot. And few things we have to remember that there should be the gentle pressure has to be applied. So little firm pressure through the globe. And apart from we have to keep in mind, we should avoid the pop sound. Pop sound is the indication of the excessive energy is used. So we have to step down the power and then continue the procedure. And we have to avoid the 3 or 9 o'clock position to avoid the damage to the long posterior ciliary nerves and vessels. And we have to avoid the places where the previous trabeculectomy has been done. So how to optimize a precise placement of probe using the long duration and longer duration, low power, and avoiding the pop sound, we will get the good outcome. So these are the various studies has been done to 2000 to 2019 and saw that continuous wave CPC produced a good IP control from 7 to 25 mg and the IP reduction from 29 to the 60%. The mean reduction IB from 0.2 to 1.93. However, this is a good procedure. However, this procedure was associated with vision threatening complications like hypertony, prolonged inflammation, loss of vision, and phthisis bulbi. So there's a new laser coming recent time. New laser coming. This is called the micropulse, and it's become popular and increasingly being used for glaucoma with good vision. So what is micropulse? It is a technology that finely controls the thermal elevation by chopping a continuous wave beam into the repetitive sort. So here we can understand this is 33.3 duty cycle. That means the energy is delivered in micropulse only for the 0.5 millisecond. Then there is a resting period of 1.1 millisecond. And then again, energy delivered from the 0.5 millisecond. Thus, the micropulse nature achieve the targeted tissue damage and decrease the damage to the surrounding tissue. So how to do it? It can be done at the peribulbar or subtenal anesthesia, and it needs the coupling agent. So this probe is showing the generation 1 probe, and this is the generation 2 probe. So just to identify, this is the bunny-like projection is present in the generation 2 probe that we have to keep in limbus. Generation 1 we see in the video. So this is the power setting we have to keep around the 1600 to 2500 milliwatt and 50 to 80 millisecond. These power setting all depend upon the eye and the preoperative IOP. We can change it. So this is the surgical video. So after putting the peribulbar or retrobulbar block, we have to hold the probe like pen-like position, and we have to apply a lot of the viscoelastic around the limbus, so it will be easy to the sliding movement around the limbus. And the speed has to be little slow. It all depends on the how much duration you require. Usually we do for the 80 seconds for the each hemisphere. So the post-op regimen, we have to keep the steroid antibiotic dose 4 times a day for 4 weeks and tapered, and cycloplegic for 1 to 2 weeks. And anti-glaucoma medicine has to be continued. It has to be tapered according to the level of IOP. So what is the problem with micropulse CPC? This cost is a big challenge for micropulse because single probe is costing 25,000 rupees, and it's activated only for the 90 minutes. So make it the cost effective, we have to pool the cases, 3 to 5 cases, then we can do. If more than that case we do, the efficacy has been borne down. Apart from that, there's a mild inflammation and febrile reaction that is go with the steroid. It's not a major problem, but major concern about the micropulse, 20% of the patient have the vision loss in 1 to 2 lines, and some patients experience the pupillary dilatation for 4 to 5 mm. And few patients report the epithelial haze and neurotopic keratitis. However, the only few cases have the corneal detachment, but they are most of they are the self-resolving. So these are the studies has been done, and they come summarize the micropulse has good IP control, but this IP control is much less than the continuous wave. It is 6 to 17 mmHg average, and percentage of IP reduction is at 27 to the 46%. And mean anti-glaucoma medication reduced from 0.5 to 0.16. We did one study at our center, prospective non-comparative interventional trial. We recruited 56 consecutive refractory glaucoma patients who underwent micropulse, and we usually keep the standard setting for the 2000 millisecond and the 2000 milliwatt for the 80 second for each year. And we find out it's a good IP control. IP dropped down from 35 to the 17 mmHg at the 6 month, and the percentage of IP reduction was 43% at the end of 6 months, and we achieved the good success rate in 6 months around the 87%. So the various studies have shown POG have the better outcome, and the higher power and the lower baseline IP have shown the better outcome. So coming to the, just to summarize, micropulse CPC is a safe and effective alternative to continuous wave CPC, can be used in moderate and advanced glaucoma with good vision. Micropulse may reduce the need of medication, but complete success unlikely. Fewer complications than CPC, currently not recommended as a routine primary therapy. Thank you for patient listening.
Thank you, doctor. That was a very thorough talk. Murli, you take a question, or shall we go on to Dr. Sushmita? Because we are running late.
I just wanted to ask Dr. Devendra Maheshwari as to whether you have repeated micropulse cyclophotocoagulation, and if so, how many times is the maximum that you have repeated? In case the first MP TSCPC failed to control, have you repeated this cyclophotocoagulation? What is the maximum number of times that you have repeated?
We repeated only 3 times till now. We have a few patients. We don't repeat more than the 2 times. Total three microbuds we have tried in one patient. Apart from that, if fails to convert, I think they need the other procedures.
Okay.
Thank you. We shall now go on to our next dynamic speaker, Dr. Shushmita Kaushik, who's a professor of ophthalmology and senior consultant glaucoma services at PGI Chandigarh, and a very dynamic national figure, and has contributed enormously to the glaucoma in our country and international standing. And she's going to be telling us about exciting new developments that could change the future of glaucoma surgery. On to you, Doctor.
Good evening, and thank you, Dr. Chitra, for having me on this exciting webinar. So, for me, the horizon of glaucoma surgery is primarily reorganization of indications. And I don't think there is a debate between MIGS and trabeculectomy, because I don't think MIGS will replace trabeculectomy, because there are aging populations around the world. There are progressing glaucomas. There are advanced glaucomas who come to us who will need low IOPs in the low teens, and trabeculectomy is going to hold the answer. So will it bring in a change in the paradigm? Most likely, yes. Early glaucomas usually are treated with pharmacotherapy, moderate glaucomas in 3 to 4 drops. And now we are going to consider surgery, but we are going to avoid doing trabeculectomy, and we're going to consider minimally invasive surgery. So this is really the snapshot of what we have. We have the outflow stents, the iTrack and Hydrus. We just heard one talk on that. Dr. Craig touched upon the iTrack and Omni for viscocanalostomy, in which you could click, and there are little aliquots of visco that are injected. And of course, you could strip it by a Cahook dual blade, or even cheaply by a bent angle needle goniectomy or a bang. But I don't think MIGS is on the horizon. I think MIGS has arrived. And the thoughts for the future, conversely for me, is many more patients now are being referred for a trabeculectomy. And we absolutely still need a trabeculectomy in the future. And for a glaucoma specialist of the future, we need to learn trabeculectomy and understand the follow-up. It does not mean you cannot and should not also embrace MIGS. The future lies in providing the appropriate choice. It's individualized, and it's based upon what each patient needs. So my wish list for a future of treatment would be slow release drug delivery systems for medications, rather than people putting drops, where the ocular surface toxicity would be minimized. The development of an ideal glaucoma surgery, as Paul Palmer keeps saying, the 10-10-10, 10 minutes, 10 millimeters of mercury lasting 10 years, and that's still on the horizon. Quick visual recovery and less sight-threatening complications. And finally, the RGC neuroprotection or regeneration of those which have gone, which is again on the horizon, a stem cell or gene therapy. So what's really on the horizon is Duristra, and I'm talking about India, because it's 10 microgram in a rod-shaped biodegradable polymer with a 200 micron diameter. If it's FDA approved only for a single injection. And there are 2 trials, the Artemis 1 and 2, which have looked at, and phase 3 trials have 3 injections at day 1, week 16 and week 32. And the IOP assist at week 52, which means a year after the last implantation, was lower than timolol. So that's where we stand. It's not huge, but it's something. And the other thing on the horizon, which is not FDA approved as yet, it's still in phase 2, is iDose. And that's a biocompatible titanium implant, and that's impregnated the travoprost. So the other thing that we are waiting for in India, it's been approved in Europe, but FDA hasn't approved it as yet, is the PRESERFLO. Now this is SIBS. This is the exciting new material, which is so biocompatible that there's no extrusions or expulsions. It's just 8.5 millimeters, 0.35 millimeter diameter, and a 70 micron lumen. There are 2 anchoring wings, position 4.5 millimeters posterior. There is decreased risk for post-op episcleral scarring, and early results are promising. So there's one that has come out with 3-year outcomes in a prospective pilot of 23 patients, where at 3-year it was down at 10 with a mean of AGMs from 2.5 to 1. And I could find a FDA exemption trial in children, so that caught my eye. Jamie Brand did that, 12 eyes of 12 children. They range from 15 months to 14 years, and the pressures were down from IOP of 22 to an IOP by 45% to about 11 at 1 year. And 7 of these children did not require medication as yet. So these are early things yet, but it's very easy to put in. It just takes about 10 minutes, and that's something to look forward to. The next thing on the horizon is for glaucoma drainage implants, and we're looking forward to these implants in India to augment the AGV and the bar welt that we have. There is an Ahmed clear path which is valveless, but it's preloaded with a ripcord. So that's something which could be very exciting, because I know Orolab is developing a 3.0 Supra Mid, and we're still looking for a multi-filament nylon, and this ripcord will already be preloaded in it. So you just need to put it in, and you take out the conjunctiva, take out the ripcord and implant it under the conjunctiva. And there are 2 sizes available, the 250 and 350 millimeter square. So the minute it's going to be introduced in India, we're all going to be happy to use it and see what happens. And the other thing which is very common in Southeast Asia now and very popular in Australasia and Oceania as well is a Paul glaucoma implant. And we like it because it's called the PGI. It's 342 millimeter square with a thinner lumen, a 0.127 lumen compared to the AGV and the RD, which is 0.3. And apparently this has given good results at 1 year as well. The other thing that's exciting is drug-eluting GDDs. This is something which I would look forward to, because it would prevent fibrosis and high blebs, which are bugbear, especially for AGV. So the 2 things that have been impregnated are mitomycin C and Plaxitaxel. Plaxitaxel actually has been coated with cardiac stents, and it's helped them in not reblocking and not having to re-stent the heart cardiac stent. So that's where the idea has come from. And it's experimental, yes, but paclitaxel coated GDDs should be something that we could all look forward to. And they've also been attached to slow release MMC delivery systems, so that it's a slow release of antimetabolite. Coming to the future, again, regenerative medicine. Stem cells have the potential to stop the progression of disease, and they replace tissue in the eye that has degenerated. And the other thing is regeneration of adult retinal axons. There's enhancement of neural activity combined with rapamycin, and these regenerate and re-innovate the brain. So that's been demonstrated in mice, and the next is going to be the primate model, and we're going to look at whether in vivo actually this works. So to summarize, I think the future of glaucoma surgery is all about choices and making good choices depending upon the patient who's in front of you. There's no dogma as to this surgery is better than that. The whole spectrum is amenable to some surgery or the other, depending on what you're comfortable with and what you can do. What is important is to recognize which would be the most appropriate for the best outcome for the patient who is sitting in front of us. Thank you very much for the opportunity again.
That was again a superb talk, Dr. Shushmita. We thoroughly enjoyed it. But just a brief at what we could achieve, could there be any improvement in understanding of the CSF pressure, or could there be anything about obstructive sleep apnea, or could there be anything about this 24-hour ambulatory BP monitoring? Like, would we learn something more in those directions?
Yes, I mean, there's fair amount of evidence that it's translaminar pressure that's important more than transcorneal, which is what we monitor. The problem with that is there's no way that we can raise the CSF pressure. So even if we understand it, I don't see, at least as of now, any way of raising the CSF pressure and reducing the translaminar pressure. So the only thing that we can do is lower intraocular pressure to reduce that. And as regarding the BP, again, the diastolic ocular perfusion pressure, the diastolic minus IOP, which is less than 55, is detrimental. But the problem is, if the diastolic pressure is less, again, there's no way to improve it or increase it. So the only thing that we have in our hands right now is a lowering IOP. But it's good that we are understanding this as well, and it helps to lower it further. And I think even in normal tension glaucoma, by lowering pressure, what we are doing is just increasing the diastolic ocular perfusion pressure rather than anything else, and improving perfusion to the optic nerve head.
Thank you. Thank you so much for that clarity. We shall now go on to our last speaker, Dr. Vijay Lakshmi, who's a medical consultant, glaucoma services at Isent Eye Care Systems, Madurai. And she is going to tell us something very important, optimizing management of lens-induced glaucoma. Sorry that you had to be patient till the end, but I'm sure, like us, you enjoyed all the talks this far.
Yes, ma'am. Thank you, ma'am. So today I'll be discussing on optimizing management of lens-induced glaucoma. A brief introduction. Lens-induced glaucomas are the commonest cause of secondary glaucomas. It is common in developing countries with an incidence of 2.4%. And it is seen in elderly patients, especially in females. Most of this lens-induced glaucomas, especially phacolytic and phacomorphic, they present as ophthalmic emergencies. That is, they need immediate surgical intervention within 48 to 72 hours of presentation. This is because acute rise in intraocular pressure can lead to compromised function of the optic nerve. As we all know, cataract surgery is the treatment of choice in all these patients. So to achieve optimum visual outcome, there has to be certain pre-operative, intraoperative, and post-operative care, which I will be discussing in subsequent slides. First is pre-operative clinical assessment. Proper documentation of perception of light and projection of rays is very important before taking up the patient for surgery. So few patients may not cooperate for perception of light, and in some patients, PR can be inaccurate. Still, inaccurate PR is not an absolute contraindication in proceeding with cataract extraction. And proper documentation of slit lamp biomicroscopic findings like corneal edema, presence of any bullae, and density of cataract, whether it is a intumescent cataract or a hypermature cataract, any subluxation or any phacodonosis, everything needs to be documented in the slit lamp examination. And IOP recording by aplanation tonometry is also mandatory. If a patient is going to be a phacomorphic glaucoma, documentation of gonioscopic finding in the fellow eye is essential, because few patients can have occludable angle in the fellow eye, which needs prophylactic laser treatment in the fellow eye. In patients with inaccurate PR or patients who are not cooperating for perception of light, then we need to plan a B-scan ultrasonography for proper documentation of posterior segment findings, and accurate biometry is also mandatory. A proper documentation of a signed guarded visual consent form is very essential, anticipating all the intraop complications, even the risk of expulsive hemorrhage, need for resurgery, and prolonged visual recovery. Everything needs to be documented well before taking up the patient for surgery. Now, coming to preoperative management part, reduction of intraocular pressure as well as control of inflammation is very essential. So intraocular pressure reduction can be achieved by using ABC, that is alpha agonists, beta blockers, and carbonic anhydrase inhibitors, both topical and systemic. In few patients who are really symptomatic or in whom the intraocular pressure is very high, in the range of 60 to 70, then we may have to plan a dose of IV mannitol or oral glycerol. The drugs which are contraindicated in these patients are PG analogs and pilocarpine. And inflammatory control can be achieved by topical steroids, and cycloplegics is needed in patients with phacolytic glaucoma and lens particle glaucoma. So regarding intraoperative challenges, so since we are going to deal with the globe with a very high intraocular pressure, there is an anticipated chance of expulsive hemorrhage, and also achieving a proper rhexis is going to be technically challenging due to poor visibility as a result of corneal edema and absent red glow due to mature or hypermature cataract. And these patients can have coexisting inflammation and pseudo-exfoliation, which can lead to poorly dilating pupil, and also chronic zonal laxity can lead to difficulty in rhexis. So I'll be showing you a few videos of how cataract surgery is done in a patient with phacomorphic glaucoma. This is a 64-year-old patient who has been diagnosed with phacomorphic glaucoma with an intraocular pressure of 48, and he had been treated with topical and systemic anti-glaucoma eye drops and steroids. And under IV mannitol and subtenon anesthesia, the patient is taken up for cataract surgery. So, after conjunctival peritomy and cautery, a 6 to 7 mm of sclerocorneal tunnel is made. And then adequate care has to be taken to create adequate side pockets, because these patients are going to have a intermittent brown cataract. Next comes the most important step, that is controlled paracentesis. Since these patients can have shallow anterior chamber as well as peripheral flat AC, risk of iris prolapse as well as touching the ALC is going to be high. And then the ALC is stained with trypan blue dye. Tunnel entry is made with bevel down keratome. And next comes the most important step, that is decreasing the intralenticular pressure by making a small nick in the ALC and letting the intralenticular fluid to come out of the bag. So this gives us some space to operate in the anterior chamber. Once the adequate rhexis is achieved, nucleus can be gently wheeled out of the bag using bimanual technique, either spatula in one hand or Sinski in one hand, or a viscocannula in one hand or Sinski in the other hand. Then the nucleus is delivered out by means of irrigating vectis method. A gentle cortex wash is done and 3-piece IOL is placed in bag. So this is a patient with a phacolytic glaucoma whose pressure are in the range of 60s and who had been treated with topical and systemic anti-glaucoma medications as well as steroids and cycloplegics. And this patient is also taken up for surgery under IV mannitol. Here you could see there is a poor visualization of ALC due to corneal edema and lens particle in anterior chamber. A gentle paracentesis is made and lens particle in the AC is cleared using a saline cannula. AC is formed with viscoelastic. As you could very well appreciate, the pupil is very small. So the pupillar dilatation can be achieved by using a double Coughlin's hooks or a multiple sphincterotomy or iris hooks. Once adequate pupillar dilatation is achieved, a control ALC entry is made with bevel keratome. So this avoid the rhexis extending to the periphery. The anterior chamber is formed with viscoelastic and the rhexis is continued with rhexis forceps. So here you could see the liquefied cortex is hampering the view of the rhexis margin. So it can be cleared by using a viscoelastic. And the rhexis part can be continued. So once the rhexis is completed, nucleus is going to be really small in these patients. So nucleus is gently wheeled out of the bag using bimanual technique. And nucleus is delivered by irrigating vectis method. So care has to be taken that we avoid sudden decompression of the globe. This may lead to whole bag removal.
1 minute remaining now.
A gentle cortex wash is done. And 3-piece intraocular lens is placed in bag. And here the most important step is we need to take care of clearing the angles also using the Simca cannula after placing the lens, because to clear the lens particles and inflammatory materials in the angle structures. So we can do a aspiration of the liquefied cortex using the 26 gauge cannula also. So here the pupil dilatation is achieved by using a Vanna scissors. So once this is done, a 26 gauge cannula is introduced, a small ALC nick is made, and liquefied cortex is aspirated using a 26 gauge cannula, and then the anterior chamber can be formed with viscoelastic and the surgical steps continued as described earlier. So this is a challenging case. Here you could see the phacolytic glaucoma. The patient is having a calcified ALC with a poor visualization also due to corneal edema as well as the lens particles in the ALC. So the lens particle is cleared from the anterior chamber. So whenever the surgeon is trying to attempt the rhexis, here you could see the zonal laxity. So the calcified ALC is cut with Vannas and then the surgical step is continued. Now coming to the post-operative care, these patients may need intensive topical steroids, cycloplegics, and topical and systemic glaucoma medications may be needed in immediate post-operative period. And a short course of oral antibiotics may also be needed if the patient is ending up with whole bag removal or PCR. And short course of oral steroids may also be needed in patients with persistent inflammation. And regarding the choice of phaco or SACS, in our setup, we prefer doing SACS because it is much safer than phaco because it causes less stress on the zonals. Whereas in phaco, there could be poor visibility due to corneal edema and also shallow anterior chambers with hard nucleus. It can lead to increased risk of endothelial damage. So choosing the option between SACS or phaco, whatever is safe in surgeon's hand, they can prefer the surgical choice. And next, the doubt is whether to plan for cataract extraction alone or a combined surgery in patients with phacomorphic glaucoma who is presenting a little bit late. So Senthil et al. In this study, they have revealed that both the group, they have shown a similar IOP control, but still the cataract extraction group, they had a faster and better visual recovery. And in patients with painful blind eye, diode CPC can be considered. And thank you for this opportunity. Thank you, ma'am.
Thank you very much. So I'm going to just take one question, and Murli could also ask. Dr. Krishna Das, you're there.
Yeah.
Now, would you, what is the significance of a patient not having a perception of light? Would you still go ahead and do surgery in these patients?
Sometimes, it's very difficult for patients to appreciate even light perception, given the density of cataracts, corneal edema, high intraocular pressure, pain, etc. So, going by slit lamp features, if there is no evidence of chronic corneal edema, especially in phacomorphic glaucoma, like corneal neovascularization, persistent chronic corneal edema, iris neovascularization, suggesting very long-standing glaucoma. And if you just have a streamy cornea, and the features suggest history, both clinical features suggest that the onset of glaucoma has been recent. Even if the patient is not able to perceive or project the lights accurately, we can go ahead. I think even the literature says, especially in phacolytic glaucoma, in very many cases of phacolytic glaucoma with very high intraocular pressure, sometimes the patient may not be able to project or perceive light. I think it is better. It makes sense to go ahead with surgery.
Murli, can you take the next question?
Yeah, I have a question for Dr. Swati. Dr. Swati, do you do most of these GATs in the topical anesthesia, and what would you do if the patient suddenly becomes uncooperative, especially with head positioning or with looking to the opposite side? What would you do? Have you done it under block?
Yeah. I do it under subtenons only, because once I tried doing in topical, it was a bang case, bent tab interno needle goniectomy. I thought it will be small procedure only, I can get away with topical. But then I had a real problem, because once you turn the patient's head on the nasal side and you tilt the microscope, but still the eye can move. So the patient was turning the eye towards the temporal side. So it was very difficult to maintain positioning. So I prefer doing it in subtenons.
Do you use a funnel traction switcher or thing to position here?
No.
Have you tried this GAT in neovascular glaucomas?
No. Normally, also it bleeds so much that in neovascular glaucoma, I won't dare to.
Dr. Shushmita, what is the percentage of patients in lens-induced glaucoma who actually need glaucoma surgery?
So I think that depends upon the duration, but I would be comfortable with first taking out the lens and taking a call, because I can't see the disc. I don't know what it's like. But and I think combining a trabeculectomy always is more morbid with cataract surgery. So in any case, I would tell the patient, look, you're most likely going to land up with a glaucoma surgery, but let me take out this cataract first and then see. I would always do sequential.
Yes. Dr. Harshul, would you think of doing a limited vitrectomy in these very highly pressurized eyes besides the medical management? Have you ever needed to do that?
Yeah, I think that a very good point. I was just trying to say that. I don't know how you did telepathy over there, because one has to, if things are very, and you have vitrectomy surgeons with you, you can go ahead and do a small core vitrectomy to debulk the whole thing, because then otherwise, if you suddenly open it up, then you can have chances of problems.
Yes. Anything else, Dr. George? Anybody? You have anything to add? Because this is we've not covered many panel questions in this talk because of I dragged the discussion for far too long in the beginning. Anything very important for the audience you would like to ask the panel?
No, I just want to reiterate what Shushmita had said, what Krishna said, that even if PR is inaccurate, you will go ahead and do a surgery. And a lot of people keep asking, should we do a combined? So Shushmita clarified it very clearly. First, go ahead and do a lens, because lens is the cause in these cases. And then tell the patient that, yes, we may require it. Especially if after giving mannitol, the pressures are very high, then you go ahead and do a core vitrectomy if it is available to you. Otherwise, you can put in a needle also.
Very nice. Anything else? Any other question to ask?
So one question for Dr. Suhasini. Regarding the glaucoma drainage device, sometimes you have a conjunctival erosion over the patch graft. So how do we manage that?
Suhasini, I think she's not there.
George, can you answer that?
Can answer this?
Murli, what is the time at which this erosion has occurred?
So, sorry, sir?
No, I want to know whether this erosion is immediate post-op or late post-op. Conjunctival erosion over the patch graft.
In the first 2 weeks of surgery.
Usually, epithelialization will occur, Murli, over that area. If it's a small erosion and it stays there. So I don't think we need to do anything if it is right above the patch graft.
Yes. I think everybody has to go back for their dinner. So I think we will come back with a different interesting session on glaucoma maybe in August, and make it fewer topics and a lot more discussions. I think a lot more will be gained in that. And thank you very much for the amazing contribution of the expert panel and so knowledgeable and informed speakers. Like I felt all of you speakers could have been the expert panel, and that is the level of confidence you all showed in the way you showed your amazing videos. It was truly a great webinar, and I feel I learned a lot in this. And of course, I need to thank my co-moderator. You all have just no idea what an amazing support and energy has always been through all my webinars. May apparently look quiet, but that gray matter of his really has too many convolutions in it. And again, I think I need to thank AIOS admin, Mr. Kripal, and his team for always being so supportive in our webinars. Sai and Manjula for Numerotech. You can see you must be tired of getting my mails, but please do remember me for the next term when I would stand for the same post. Don't give up on me at all. I'll try to come in a newer, innovative way of having an academic reach for you all. This is not meant for canvassing. This was just a light way, and I said that.
And, Chitra,
yes?
We are planning to have you as a permanent AIOS chair.
My husband might divorce me.
Only if you promise to send dinner by Zomato in these kind of meetings.
I know, very true. And of course, I think I definitely need to thank our sponsors, Entoad, who have been really, really wonderful and constantly there to sponsor every single program of ours. I need to truly thank my ARC team, although they have not been here, but they've always there in the background supporting and encouraging me forward. And thank you to all our dear attendees. We've had a good number of attendance, and would you believe it, the number keeps increasing with time. And on Sunday, please don't miss the my email. Don't overlook it. It has one beautiful ARC video coming with it, which will actually tell you that the future is the webinars, the kind of attendance which has come across, and I have put across our ARC activities very nicely. I look forward to comments from at least this panel after you see that video on Sunday. And thank you so much, one and all of you. Look forward to meeting you all again and again on this platform. Thank you.